Hello, you are, and you, Hugo. How you doing?
Mhm. Yeah. Hi, John.
How you doing?
How are you?
Good, good. Yeah, you're your co-host. Everything's okay. Yuha's here. Hello, Yuha.
Hello,
Yuha.
hello, John.
Yeah, I want you to meet Sam. Sam, you there?
Yes, I am here.
Oh, hello, Sam.
Yuha,
How?
this is the guy that's going to help change education in Arab neurosurgery.
He's working very hard on it. Yeah.
He's working. Sam is working very hard.
Thank you, John.
Okay, your co-host, Sam.
Thank you, John.
Let me get off my pin. I'm pinning myself. I gotta unpin my unpin. Okay, there we go. That way.
Okay.
Yeah, is your camera working, Sam? There
Now
you go.
it's okay.
There you go. Look distinguished.
Thank you.
Very
Thank you.
distinguished.
Thank you.
Okay. I guess we're all set up. We have 17 minutes, and um, d- uh, Michael knows about the conference, right?
Yup, yup, yup.
Okay.
I just reminded him just now.
Oh, good. Okay. Yeah, he's a pro. He's been around.
Yes.
So, Yua, how was the audience?
This time, not so much. I think there's some overlapping, 1,500.
Oh, okay. So down a little bit, huh? It's okay. That's a lot of people.
Now in China, not so many.
Yeah. How about at the hospital? Do they know you're doing it? Does the administration know you're doing it? And
Yeah, they know.
they don't, I hope they watch it.
Administration, not some of the neurosurgeon and endovascular, certainly.
They know, huh?
Yeah.
Yeah, sure. If they want to do more, they can do. I'll do as many as they want. If they want to do more, other than you, you know.
Yeah, they get interested. I think they get interested. They are.
Yeah, they
slow
could do
in the
another night.
beginning, but yeah, they have good cases. They have good cases, so they should do more.
Yeah, they could do another night if they wanted,
Yeah.
another day, their own hour, their own time,
Yeah.
if they want.
Yeah. Let's see.
Okay. Yeah, because at first it's
I have
very
to
different.
push very hard.
Yeah, at first it's different to everybody. They don't know what it is to understand it. But
Yeah, you
once-
had also to push me very hard to do this.
Yeah.
You
Well,
pushed me
that-
very hard, John.
I
to
know.
do
I
this.
had to, you. No, but you were easy because even in Baratnagar, you like to use it. Back there, I don't know if you remember, I interviewed you for Finnish.
Hello, dear John.
Hey, Nick, how you doing?
My greetings to Professor Chernesniemi. Hello, dear professor.
What are you in the shower?
Yes, it's very hot here in Thessaloniki, Greece.
Oh, really? Really?
40 grades Celsius.
Oh my goodness.
Wow.
Oh my goodness.
So that's right, summertime, huh?
John, you are a myth of the Zoom meetings. You are a giant of the Zoom meetings. And
No, there are a lot of giants. There are a lot of giants now. There are a lot
and
of.
Professor Chernesniemi is the giant of the vascular neurosurgery.
There you go. There you go.
One of them.
The world is getting smaller. Now you're in northern Greece, right, Nick?
Yes, I am in Thessaloniki, from Thessaloniki, the northern part of Greece.
Now that's the area of Alexander the Great, right?
Yes. We will invite, in the future, we will invite Professor Chernesniemi to give us a lecture.
Oh, okay.
Yeah, in the Greece, I'm involved in the Greece meeting now in September.
Yes. In the end of September, you will be in Athens, Professor. Yes, I know.
Yeah, I'm involved.
I will be there.
To lecture. Yeah, I will be there. Yeah.
Athens, a wonderful town. The best museums I've ever seen.
All the Greece is wonderful, John.
Oh, I loved it. I was there for a week. I loved it. I
Yes,
spent 3 days in Athens, but it was not enough. There's so much to do in Athens. If you like Greek history, there's so much to do. Okay, Sam, are you okay?
Yes, yes, I am here.
Oh, okay. So Sam, I'll just introduce you and then you just run the show, the whole thing, okay?
Yes, yes, it will be okay.
Yeah, when of
Thank
course you when a speaker finishes it, you know to take over and direct the questioning or do whatever you want to do, okay?
Yes, sir. Yes, sir.
You're in charge. You're in charge. You know what to do.
Thank you, John. Thank
Sure.
you.
So did you sleep at all, Sam?
Not very well.
I know.
As
You've
you
been
know.
really dedicated yourself to this project.
Yes, yes.
Also, my greetings to Sam. Hello, dear Sam. Compliments and all my best wishes.
Thank you, sir. Thank you. It's my pleasure.
Yeah, Nick's not trying to be racy. He's just it's hot in Greece.
I don't know how many grades of Celsius has Sam. Now in Greece we have 40 grades Celsius. It's very hot.
It would, okay, yeah, there you go. You know, Sam, when I introduce you, I would like you not to be on the screen share, okay? So we can see your face. But you want to test it? No, you know what I mean? When I introduce you, people won't be able to see you unless you're off the screen share.
Yep, yep.
So
Okay.
well, you can. Did you want to test the screen share or something?
No, for me it's okay. We are just waiting for Professor Lawton to start our session.
Okay. Oh, there's Manas. Okay. Is Dr. Borber coming today, Sam?
He said he will try,
Okay.
but he will be for sure coming tomorrow.
Okay. Oh, okay. Okay, 8 minutes.
Hello.
Hey, Manas, how you doing?
Fine. How are you?
How you been?
Fine. Doing well.
I see you're staying busy.
You are busier.
Yeah, you have another conference coming up, right? Just in a couple of days.
Yes.
Why don't you screen share and show the people in the waiting room about it?
Pardon?
Why don't you screen share it to show the people in the waiting room about the conference?
Yeah.
Go ahead, screen share. This is free advertising.
Yeah, okay, okay. I didn't plan that. I could have done that. Yeah.
Oh, okay. Because I do it with mine. Matter of fact, with Yuha, who's here, during his conference, I showed a banner of this conference. I said, okay, in an hour, we're going to be doing this conference.
Okay.
Just like they do on television, you know.
Next
Kind
time
of
we'll
tell
do
you
it.
about what's coming up. It's a
Hello,
mixture
Dr.
of
Hassan.
television and video conferencing.
Okay.
Okay, Sam, 6 minutes, Sam.
Okay.
You know, Sam, I don't know what happened with that registration. I don't remember setting it up. I mean, it's working out fine, and I'm learning.
Yeah, it's working. And I got the message.
Yeah, it worked. Have you done the registration yet, Manas, at all?
Yeah, I have done.
Yeah, I did it for the first time. I didn't realize. But this is a 2-day event. I thought that, well, maybe Zoom just automatically puts it on registration mode if you have two. Oh, good. The musical director is here. I've got to play this. Yeah, I've been asked to play
Yeah.
this special request, Manas.
Okay.
Oh my God, seriously? You did that? I'm in shock, John.
Did you like that,
Seriously.
Joanna?
I'm in shock. Like, seriously? Where did you find that?
Okay,
Why
okay.
not? Why not?
Why?
It's before
Dear
we even
John,
start.
John,
What are you doing?
please.
Exactly.
Just a little entertainment, Daddy.
Oh my God.
I'd like to greet my Professor Dr. Lawton, which he has signed in just now.
Yes, I'm here. Can you hear me?
Oh, okay.
Yes, sir. Welcome.
Thank you. Nice to be here.
You're welcome. You like coming at the last minute.
Sorry
Yeah,
about
that's
the
good.
dramatic entrance, but we're in Phoenix. It's grand rounds time, so I was just
Oh,
trying.
really? You just came from there, huh?
Yeah.
Okay, we have 3 minutes. You know, Michael, I would like to televise grand rounds, but I know there's all kinds of security problems, right? And privacy issues.
There can be, but we have been posting our grand rounds to our website, and we would be fine with televising. We should talk about this.
Yeah, we would love to do it. It's just take the measures to secure it and to make it private. So that would, I think it would work because no one's done it on a large scale basis in the world. It was broadcasting grand rounds.
Yeah, yeah. We started doing it in the whole COVID thing because of people's interest, and we've got it now so that we have the platform, we have the speakers. We could pull that off.
Yeah. Okay. Well, we'll talk about it. I would like to see all hospitals doing it.
Yeah, I think the problem is we all are running out of time to see all these great webinars around the world.
Yeah. Well, they'll reach a point where you just do as much as you can. But I think that's certainly an area which, if we can televise part of the day of a neurosurgeon that already doing it anyways, so he doesn't have to go out of his way. He's already there.
Right.
So we wouldn't have to make time. We're just televising what he's doing.
Yeah. Yeah, it's a great idea. Yeah, but let's talk about it.
Okay.
Okay.
Hold on, Sam.
I
We got
think,
one
it's
minute,
time
Sam.
now.
Okay. 1 minute, Sam. Okay.
Okay. Okay.
We're exact.
Did I see Yuha on there somewhere?
Yes, he's here. Hey, Yuha, say hello to Mike.
Yuha, good to see you.
He may have stepped away. Yuha, are you there? He may have stepped away. He's here.
Also, Professor Goel is here.
Yeah, he's here
Hello,
too.
Michael. Hello, Atul.
I had
Okay.
Tool. Every time I
Hello.
speak, I see a tool, so I know he's there.
Okay.
Okay.
Mike,
Hey,
I want
Mr.
to hear
Zoom.
a wonderful presentation from you. I'm looking
Okay, how you
forward to
doing?
your presentation.
Okay, we're ready to start. 10. Hello, Atul. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We are very proud to be collaborating with a real mover and a shaker in the Arab neurosurgery world, Sama Al-Morsi Hassan, and I'll turn it right over to him. Welcome, Sam.
Welcome, dear John. We will just start now.
Okay. Could you
Give me-
please say a few words about yourself, Sam?
I will.
Okay.
Please give me
It's okay. It's okay.
more seconds.
No problem.
Okay.
I think we can all can relate to tech. Okay.
Okay. I think it's okay now. Can you see
Yeah,
my
it's perfect.
screen?
It was on. Oh, there. Perfect.
Okay. We will start now.
Okay.
Greetings from Egypt. Between masters, mentors, and highly prestigious neurological surgeons today, I have no words to say. It's no doubt that time will stop now to mark this day and this time as century event. On the academy team was visionary of future. And before anyone started online academic education of neurological surgery, we are pioneers of teaching neurological surgery. As we have started these activities for more than 4 years before COVID. And during this period of time, day by day, Evans was compete only itself. It's always upgrading, not every year or every month, but every day. Evans is formed of 33 groups with selected members now exceeds 17,000. Every period of time, we refine our members to be sure that all are neurological and spine surgeons. Today, I'd like to talk few minutes about study groups. We have till now 6 study groups of 33 groups. Basic group for study Greenberg with more than 260 lectures till now. Neuroanatomy to study Roton and other neuroanatomy books and separate neuroanatomy lectures. Advanced group to study humans surgical approaches, to study neurological surgery approaches, clinical rounds to simulate colleague staff round, operative techniques to study suite operative books and neurological surgical books. Making a group is an easy job, but making a big family which care about each other is not an easy job at all. What we have gained from all this work, we gain no money, but we gain very, very big family that carry all respect and love for other family members and ready to help him to advance himself without any personal benefits. In the Academy is a family that have 17,000 members. In every part of world, you will have part of this family. Every day on Ewens Academy represent an international conference with daily activities that can exceed activities on the hugest online sites for neurological surgery in a year. Creating followers on social network may be easy, but creating active participants to make a specific mission on unfamiliar program for most of them is an extraordinary effort. Then creating leader of them need more efforts. To make the golden name of Ewens Academy need more and more efforts. Do you know why no one can make better than Ewens? It's because we are faster in development than rockets. We care with every statistical number that we have, and we master it with most advanced statistical programs. Every day, no, but every minute in Ewens is a revolution of science, with using every single updates of programs that we use it to the maximum to serve our mission. To serve our mission in developing our neurological surgery specialty and its subsequent subspecialties. Telegram, LinkedIn, Facebook, Twitter, and WhatsApp. And last updates of WhatsApp give up broadcast that we have 10 of them for Ewens till now to get the fastest way to reach our members. At last, I'd like to thank our speakers, mentors, and organizers for this century event. And now, with our dear mentor, Professor Yuha, to start our ceremony. Thank you so much. Thank you.
Okay, very good. Thank you, Sam. Okay, do you want to introduce first speaker, Sam?
Our first speaker need no introduction, but will our Professor mentor Yuha will start our session. Please, Professor Yuha, can we start?
Will be the first lecture will be by Michael Lawton. I think all the world knows him well. He's the chairman and professor at the Barrow, successor of Professor Bob Spetzler. This is legendary place and by many called as #1 center in the world. So we are waiting, interesting the guidelines for taking care of brainstem cavernomas, which there is huge experience at Barrow on the treatment, surgical treatment of brainstem cavernoma. So I think this is the largest series in the world. So please, Michael, go ahead.
He's muted.
You're muted. You're muted.
There we go. Can you hear me now?
Yes.
Yes, we can.
Okay, good. I'm going to share my screen and I'm going to go to my presentation mode. Can you tell me if you see my title slide?
Yes. Yes.
Surgery for brainstem cavernomas malformations.
Yes. Perfect. Perfect. Well, Juha, it's always great to see you. You look well. I trust you're doing well in China, and it's so nice to see you. Thank you for that introduction. Thank you for the Academy for having me here to speak on these brainstem cavernous malformations, which, as Juha said, I think we have the largest experience in the world with these. Between Dr. Spetzler's work and my own, I think we have really become the place for this. And so I wanted to kind of share with you my take on this. On this disease. So this first slide just summarizes my personal experience. You can see if you add all these together, over 1,000 cavernous malformations that I've taken care of over a 23-year period. And what I thought I would do is just try and distill for you some of the lessons learned. I am trying to capture all this in my next book, 7 Cavernomas. It's in progress. The goals of the book are to develop a taxonomy for surgical approaches to advance this idea of tissue-sparing approaches through the subarachnoid spaces, which I think is the beauty of cavernous malformations. Unlike glioma surgery or some of the other surgeries we do, most of this surgery can be done by approaches through the subarachnoid space. And then finally, it's a really ripe area for applying AI technology. And so we have an AI center here at Barrow. We're trying to apply that to some of the decision algorithms that we make. And it's an exciting project, but still in progress. These are some of the tenets of the book. And I will touch on some of these things. You know, I think the first is just thinking about subarachnoid corridors to get to these lesions. And since 7 is my favorite number, I think about these in 7 corridors as well, either through gyri and sulci, through the sylvian fissure, down the interhemispheric fissure, through the ventricles, along the tentorium, through the petrous bone, or through the foramen magnum. So these are really the different corridors that we exploit to get there. This is a picture of my beloved Marin Headlands in California, where I spent 20 years living and working and raising my family. And when you look at this scenery, you can't even see San Francisco in the distance. It's way over here in the, you can see a tower there, but you see these rolling hills, and it's very easy to get lost in this open space. And what makes the difference is these trails. And if you understand the grid or the network of trails through the Marin headlands, you can navigate this space and get to really some beautiful vistas, some great landmarks, and ocean views, city views, and what have you. And I kind of view navigation and brain surgery in a similar way. This is how we've translated this idea of maps and AI and navigation to a Tesla. This is a view of the Tesla taking me home in the evening to my house. But I think we can do the same with these approaches. And one of the things that is so pivotal is really understanding the arteries. The arteries are really like those red lines on that map that I showed you. And if you really understand the arterial anatomy, and if you think about it or talk about it in terms of segmental anatomy, then every piece of that vascular tree has an address. And you can use those addresses in the same way that the GPS uses your position in your car to take you down the highways or down the roads to your house. And so that's kind of
Oop, lost the audio there, Mike.
You need to change the slides also, because we are seeing two slides, the incoming slide and the projected slide, presenting slide.
Can you hear me? Did we?
Yeah, now we can hear you. Yeah.
Oh, was I muted before?
Yeah, just for a few seconds.
Oh, okay. You caught all the other stuff?
Yes.
Okay. All right.
Yeah.
Sorry about that.
But Dr. Lawton, we are seeing two slides in your presentation, one the incoming slide and the presenting slide. Can you do
Okay.
something about it?
Let me do this. Let me reboot here. Hold on a sec. Yeah, okay. For some reason it switched.
Okay. Take
Let me
your time. Take your time.
share this one. And let me play that. Can you see now one slide or two?
Can see one.
Okay, good. Right. And I think this is where I left off before. It
Yeah,
says,
segmental address.
yeah, okay, good. Right, so the idea here is once you know where the malformation is and you find its relationship to the arterial system, you can use that as a way to navigate the subarachnoid spaces. That's the idea that I was getting at. The next idea is that of triangles. I feel like what really helps me in navigating some of these spaces is to use nature's triangles to orient ourselves. And these are examples in aneurysm surgery of triangles that I found really valuable. This is one that we published just a year or two ago, this junctional triangle between the A1 and the A2 that's very useful to help mobilize the recurrent artery out of your way and get to ACOM aneurysms that are superior or posteriorly projecting. Here's another one, what we call the pre-communicating triangle that gets you to the A1s underneath the complex for your proximal control. These are triangles that we use in basilar bifurcation surgery where primarily this carotid oculomotor triangle here is seen. Carotid optic triangle is another triangle that we sometimes use for basilar aneurysms that's a little bit more limited. And here in orange is this supracarotid triangle. Over here in this third illustration, you can see the oculomotor tentorial triangle. Here, this is what I call the bypass triangle because you have access to the P2 segments, the S2 segment, and it's a great spot to bring in a radial artery graft or do a side-to-side. But again, these are all different examples of triangles that help take us to places in the subarachnoid space where we can access surface anatomy, vascular anatomy, and in this case, cavernous malformations. Other examples of triangles, this vago-accessory triangle is one that we published on years ago. It's outstanding for pica aneurysms, great for pica bypasses. It's great for V4 segment bypasses and aneurysms. Here's another of the triangles over here, the glossopharyngeal cochlear triangle between the lower cranial nerve bundle and the 7th and 8th nerves is really valuable for petroclival meningiomas or for macrovascular decompressions and for high-riding picas and other vascular lesions like ICA aneurysms. So again, triangular anatomy that helps lead you through your critical structures to get to the pathology. Here are more triangles. Troutman's triangle is an example. Some of the suboccipital triangles in the soft tissue are vago-accessory triangle once again. But if you gather all of these together, you can see there are a dozen in the intracranial fossa. There are another dozen in the middle cranial fossa and cavernous sinus. There are posterior cranial fossa triangles. These are nature's windows for orienting you and guiding you through this, this maze of anatomy to get there. When you arrive, surface anatomy is really critical. I'm not going to spend a lot of time talking about surface anatomy because I could spend several of these lectures talking about this level of detail, but suffice it to say, when you understand the anatomy, you can then identify what we call the entry zones, safe areas where you can access malformations that may not be right on the brainstem surface, but might require a little bit of transgression of the tissue. You have to know where you can get away with that transgression and where you can't get away with that. And these are some examples of these entry zones. Now, this is a topic that both Juha and I have spent some time thinking about, and that is a cavernous malformation grading system. I focused my attention on the brainstem, and I know Juha and his group in Helsinki looked at a more global system. The reason I chose to focus on the brainstem is because in most cases, I think the spinal cord and the cerebral cavernous malformation decision-making is pretty straightforward. If there's seizures that are intractable, if there are hemorrhages that are symptomatic, these are decisions that really lead us to take them on surgically. Whereas for the brainstem, it's a lot more difficult. And so I felt like that's where we needed the help in developing a heuristic or a rule of thumb to pick patients for surgery. So we developed this brainstem cavernoma grade, and I tried to model it after my supplementary grading system, which we use for AVMs, just so people will remember. So it's got some of the same pieces of it. There's a size component. There's an eloquence component, which instead of pure eloquence, since the brainstem is entirely eloquent, does it cross the midline or not? So that's the M point. It's a metric of eloquence. V is for the venous anomaly, just like for draining venous drainage for an AVM. And then if you think about our supplementary grade, we have an age component and we have a bleeding component. And in this case, we have points assigned for age less than or greater than 40, and hemorrhage, the chronicity of the hemorrhage, whether it was acute, subacute, or chronic. And you can see in this table how you can assign these points to arrive at a grade. And what's so useful about the grading is that you can, again, like all of these grading systems, draw a line in the sand where if you're below a certain threshold, you can feel safe in deciding or recommending surgery. If you exceed that threshold, you may not. And so for this, it's the grade 6s and 7s. We put together Dr. Spetzler's BNI cavernomas and my BNI plus UCSF cavernomas, and we validated the system. And you can see here that whether you look at modified Rankin score greater than 2, or if you look at change in neurologic status or worsening, you can see that there's a rising risk as you go up in grade. And that line between 5 and 6 really is a very useful cutoff. So here's some statistics. If you have a grade 6 or 7, and if you're looking at neurologic worsening, you're going to have a 40% chance of worsening if you choose these high-grade brainstem cavernomas, whereas if you choose these low-grade ones, your risk is 12%, which I think is quite acceptable. So I would encourage those of you who are trying to, are wrestling with a decision, to maybe run it through the brainstem cavernoma scale and see what you think. This is just some more statistics looking at the area under the receiver operator curve, and our AUC was 0.73, so it's a very good guide for this. So at this point, I'm going to just show you examples, because I think that showing you case examples is a very useful way to demonstrate some of these principles. And I'm going to start with this one. This is a thalamic brainstem cavernous malformation, or deep cavernous malformation. It's a patient who presented with homonymous hemianopsia. Imaging showed a lesion, which I'll show you in a minute, that was in the midbrain and thalamus. The brainstem cavernous malformation grade was basically a 3, so under the cutoff. And for this one, I'm going to show you an approach that we published, and I'm trying to popularize because I think it's a wonderful approach. I call it the contralateral supracerebellar transtentorial approach, because it takes you to the inferior surface of the thalamus from behind. It is a great alternative to these transcortical routes that would go through a lot of tissue. It's a great alternative to a more lateral supracerebellar approach. And I think it's better than the transsylvian transinsular approach, which is another one. So here's the lesion. You can see, if you look on all sides, it's really covered or surrounded in critical tissue. You can't get there from above. You have to go through quite a bit of tissue to get there from the side. But if you look really carefully at this image here, and you look at the ambient cistern, you can go from the tectum here into the quadrigeminal cistern and around the corner to the ambient cistern and come to where this arrives at the surface. And even though it rises quite a distance up into the thalamic region, you can get there by doing this in the sitting position. So that lateral trajectory is achieved by going contralateral, starting on the opposite side, on the outside of the patient, crossing the midline and going over to the opposite side where the lesion is. That gives you that extra lateral extension. In order to get that, you need to cut the tent. And this shows you the advantage of the sitting position. When you have the patient seated and the gravity pulls down on the cerebellum, you can rise very high into the thalamic region and get to this. So it's the sitting position, gravity retraction of the cerebellum, and that allows you to ascend into the thalamus. Here's that transtentorial component. The more lateral you go into the thalamic region, the more you run into the tentorium. So you have to cut that. It opens up this corridor. You can follow the basal vein of Rosenthal around the corner, and you can get to the lesion. So here,
approach was selected. This is done in the sitting position.
Here's the video showing the position. Patient is seated. We just do a simple midline incision for this. And you can see that when you go over the cerebellum and cut the tent, you get a really nice view into that space. So here we are looking at the cerebellum. One of the first moves is just to take a little CSF from the cisterna magna down low. That relaxes the cerebellum. And now we've got this nice view here looking over the cerebellum. And we've arrived all the way at the level of the tentorial incisura just with gravity retraction. So here, straight down the midline to start, you can see we've got to march all the way out laterally. And even though I'm in the seated position as well, and I'm at full arm's reach at quite a distance, you can see that I can still comfortably operate. I'm going in between the occipital lobe here and the the tectile plate here. I'm following these branches of the PCA. And as I keep going laterally, I'm now entering the ambient cistern from the quadrigeminal cistern. This is that tentorial incision that allows the dissection to continue further laterally. And you see that just by making this notch in the tent, this is what allows the occipital lobe to retract. Now here's the angles that we achieve. This is why that contralateral trajectory is so nice. I'm swung over to the patient's right side. I'm all the way on the patient's left side. And now you see we have that perfect angle. This is now where the lesion comes to the surface. You see a little bit of hemosiderin stain right there. I have to go through about 2 millimeters of tissue, but I immediately reach the hematoma and the malformation underneath. So now you can see malformation. The resection is fairly routine. Here you can see portions of the malformation. You can see after evacuating the clot, how we can define those borders. The lesion in this case is coming out piecemeal, but you can see that nice trajectory over the cerebellum, which is here in the foreground, right by the tentorium here, and deep up into the thalamic region. And again, because I'm looking upward, I'm able to reach to the high end of the malformation. And you can see piece by piece, more and more of this comes out. Here now at the end, we've got a nice clean gliotic margin. This is what we like to see at the end, and just very careful inspection, making sure that there aren't any hidden corners. And you can see in this view how we've reached all the way to the very top and very lateral extent through this supracerebellar transtentorial window. There's a nice overview. And again, you can see how by swinging over to the opposite side, we can get that good resection. So here we are post-operatively, a nice clean cavity, and we've violated only those 2 millimeters of tissue right over here at the very bottom. So that's a nice example of one of the cases. I'm going to show you another midbrain thalamic lesion. This patient presented with hemiparesis, third nerve palsy, upgaze palsy, similar malformation, but for this one, I'm going to show you the approach from above. And this is a contralateral transcallosal transchoroidal fissure approach. And the reason I've chosen that one is that when you study these films, you see that in this case, it's not all that different from the previous one, but it comes to the third ventricle surface here, just below the fornices, and that's the ideal way to approach this one. So this is now our view. The corpus callosum here has been opened. I'm now in the lateral ventricle. We're looking at the foramen of Monroe right here. This is the septal vein here. This is the choroidal fissure here that's coming into view. This is our thalamostriate vein going into the internal cerebral vein. And by carefully following the fornix, this is the fornix here at my pointer, we can open up the choroidal fissure, which in essence is enlarging the foramen of Monroe. So I did divide the septal vein there, which is fine to do. And as you follow the internal cerebral vein into the velum interpositum, you now have this doubling of the foramen of Monroe in size in order to come directly down on the lesion that's coming to the surface in the third ventricle. So here is that view from above. We have a nice view. This is the internal cerebral vein. We've opened up the velum interpositum, gives us a perfect top-down view. And again, the dissection here is this peeling away of the lesion from the thalamic tissue. So I, in the interest of time, will speed up some of this dissection. You can see here some more fresh hemorrhage. When you see fresh hemorrhage, it's an easy opportunity to decompress the lesion internally. You can see more of the clot, that fresh clot coming out. And as we As we get to the end here, you can see this is the aqueduct looking down posteriorly. We've reached all the way to the bottom. This is a nice, clean thalamic wall here. So I'm just inspecting to make sure that everything is clean. And now this is a beautiful view. I wanted to show you this. This is through the floor of the third ventricle looking down on the basilar apex. Those are perforators coming off of the basilar. And this is the kind of view that you get when you come down directly from above. This is just another view in the back looking at the resection cavity. Here's a nice overview showing the widening of the choroidal fissure, the internal cerebral vein, aqueduct of Sylvius, a view into the atrium of the lateral ventricle. And this is that choroidal fissure taken to about a 2-centimeter opening to get this very large malformation out. So this is just another approach for the midbrain and thalamic lesions. You can see it gives you a different perspective. This was the resection achieved in this particular patient, and a different way of doing that. Now, let's go down to the midbrain proper. This is our next case. This is similar position of the lesion, but we're going to do a straight classic lateral supracerebellar transtentorial approach. The patient presented with hemiparesis, disconjugate gaze. Lesion has a brainstem grade of 2, and this is going to be a retrosigmoid approach going over the top of the cerebellum laterally, and also with extension through the tentorium. So here's the lesion. As we study this one, you can see that this really does come to the surface at the midbrain on its lateral surface, just along the crus. And so a lateral trajectory is a nice way to do that. If we look over on these coronal views, you can see the tentorium is right here. So by going along the tentorium and working our way up, we can get around this. That's why we need this transtentorial extension here. So again, I really like the sitting position because it drops the cerebellum. Gravity opens up the planes for you very nicely. You can see the anatomy of the basal vein of Rosenthal. You can see the anatomy of the third nerve. You can see the anatomy of the SCA. There are very few landmarks in this little window here, but these are your key landmarks to focus on. So this is the exposure. The patient had a prior central neurocytoma, so you saw the shunt. This is the lateral approach. I'm taking one bridging vein here that's along the tentorium. There are always these arachnoidal adhesions here laterally at the corner of the cerebellum that you need to release. But once you release those, it gives us this beautiful view along the tentorium all the way down to the ambient cistern. So this is the arachnoid of the ambient cistern down in here. I'm dissecting along the arachnoid. You'll see, once again, fourth nerve coming into view. This is one of our important landmarks. You don't see it yet, but here we do. Here it is as it comes up from the cerebellomesencephalic cistern. It's climbing up to the its dural canal in the tentorium, and you can see for the first time the appearance of the malformation on that lateral surface. So I'm at the very bottom of it. I need to look more superiorly, so I'm going to incise the tentorium. This is that cut in the inside tentorial incisura that allows me to extend my reach up. And you can see once you break through and cauterize that little tag of dura, we can see all the way up. We can follow the basal vein of Rosenthal, and you can see with that additional dissection, we see the lesion now more clearly coming to view on this lateral surface. These are some of these posterior choroidal vessels, circumflex perforators to the midbrain. We have to sweep those away and protect them. But now that we have a clear, unobstructed view, you can see how this thing has come to the surface right there. It's actually what I would call an exophytic malformation, and we can now get inside through that presentation on the surface. And the dissection at this point is similar to some of these others. You can see the stealth showing the trajectory over that lateral portion of the cerebellum. It gives us a nice view. The challenge here is to get to the upper portion, but you can see that in the sitting position, the malformation, just as the cerebellum drops with gravity, the malformation also drops with gravity. So as we work these planes free, you can see the malformation slowly coming free on the upside. And you can see a large piece coming out there. And you know, piece by piece, we continue to remove this and ultimately get all of it out. You can see that our window is small, but gravity really is making things easier and better for us. So these are the final pieces. We're seeing gliotic tissue on the deep margin here. It's nice and clean. One last piece here. And now as we inspect, you can see that nice gliotic plane. There's the gravity retracted cerebellum and a nice resection. So that's really pushing the lateral supracerebellar approach up into a higher reach by cutting through the tentorium. Here's another example of a midbrain cavernous malformation. This is presenting on the front of the midbrain here on the cerebral peduncle. So for this one, we're going to come from the front. We're going to do a transsylvian orbitozygomatic approach, just like we would for the basilar bifurcation. But instead of going to the apex, we're going to go lateral to the midline, and we're going to come to where this presents to the surface, just in front of the peduncle. So this requires a Sylvian fissure split. This is the frontal lobe here. The temporal lobe is over here. And as we split this, we get right down on the carotid cistern here, the optic nerve is shown here. The carotid is over to your right. This is the interoptic triangle. I like to release some CSF from the lamina just to relax the brain. But now the third nerve comes into view. This approach will now follow the third nerve back. You can see we're cutting membrane of Lilliquist here and following third nerve back. And as we do, you can see that interpeduncular cistern opening up for us and bringing us to the cerebral peduncle where this malformation will come into view. Here's the third nerve over here. This is the superior cerebellar artery underneath the third nerve, and just below or deep to that is the malformation. You can see once again, it's exophytic. When you choose your approaches properly, these lesions will come right to the surface. And in this case, this was right on the cerebral peduncle. I'm going to just really go to the end to show you the removal of this thing. Quite large in size, required really careful, meticulous dissection of these perforators off of the face of this. But now, once it's free, you can see I'm working it out of the midbrain. It's going to come out in one large piece. And once again, this is all through a transsylvian exposure, one retractor on the temporal pole for that pretemporal view. And here now, just an overview showing the basilar bifurcation, the third nerve, the mammillary bodies, the transsylvian exposure. Really nice route for lesions that present anteriorly. And here is the postoperative imaging. Now, going down to the pons. For these pontine lesions, the real workhorse is this transmiddle cerebellar peduncle approach. And I'm going to show you this case. This is a patient a lady that presented with a brainstem cavernous malformation grade 2. She got points only for her age, small in size, not crossing the midpoint, no DVA, and this was one that had bled acutely. So she gets a grade 2. This is done through an extended retrosigmoid approach. And here now is the imaging for this. You can see it's squarely in the middle cerebellar peduncle, right on the lateral edge of the pons, and the transmiddle cerebellar peduncle approach is perfect. So these are the key points for the technique: opening the petrosal fissure, finding the right entry zone, and then developing your trajectory. And let me take you through that. This requires what I call the extended retrosig, where you skeletonize the sigmoid sinus, you really pull the dural flap forward, and you maximize what you can get from this extended retrosigmoid exposure. Now, if you just go into the CP angle, that will take you along this blue line here, and that's really the wrong trajectory. What you have to do is you have to angle back in order to get along the axis of the lesion. So that requires that you find this trajectory along the green line. It means rotating that natural anatomic angle about 30 degrees or so posteriorly. And in order to do that, you really have to open up what I call the Sylvian fissure of the cerebellum, which is the petrosal fissure. And this petrosal fissure is the fissure that lies between the superior lobule here and the inferior lobule leading into the flocculus. It's right here. And as you open up that fissure, what you find is the lobules part their ways. You can get a much more lateral and expansive view of the peduncle all the way out to its lateral most extent. And if you use that lateral most extent as your safe entry point here, then you get the right trajectory. So let me demonstrate that in this case. This is now the extended retrosigmoid exposure. This is the view into the cerebellopontine angle, and this is that petrosal fissure. So as you split the fissure, you'll find branches of ICA. You'll see the superior lobule over here. You'll see the inferior lobule over here. And by splitting the arachnoid in between, you can get right down on the peduncle. So here is the DVA, the venous malformation, in this case, that's swept aside. This is looking up at the trigeminal nerve. And what we're going to do now is just continue to split that fissure so that we can get the right trajectory. Here's the view into the CP angle, and you see it's really tangential on the lesion. So what we need to do is we need to walk back on the peduncle even further. So I'm going even more laterally into that petrosal fissure. I'm following this branch of ICA just as I would if I were splitting the Sylvian fissure. And here now is as far lateral as I can get on the peduncle. It's where the two lobules come together, and I'm going to use that as my entry point. And when I use that as my entry point, you see how I've shifted that trajectory. Now I've got the lesion in the line of axis of the trajectory. They're paired up beautifully. And so I can go in. This is my entry zone here. I'm going to go through about a centimeter of tissue in the middle cerebellar peduncle, but because I'm so lateral, it's very well tolerated. This is just a little finger of that venous malformation, which I can divide. And just deep to that, you'll see some staining of the peduncle and finally the malformation here. So there's the malformation. By working the subarachnoid dissection and working that fissure, we get the perfect shot at this malformation. So now I'm inside, I'm evacuating some of the acute hematoma from there. And this is one that comes out very easily. I'll just accelerate. Here you can see some of the malformation in the cavity. I'm using once again my dissectors. These are, by the way, some very nice dissectors that we developed with Mizuho. And it helps you really sharply dissect these separation planes. And here, the lesion comes out nicely. This came out almost as one piece with capsule preserved. I prefer to take them out that way. That way I know that I've gotten the entire lesion. And you can see, in particular this one, you can see that nice trajectory through the lateralmost part of the peduncle into the axis of the lesion. And as we inspect, you see healthy gliotic pons around that. You can see preservation of the venous malformation. And look how lateral we are in that entry point into the peduncle. Very important point. This is the fifth nerve, totally protected and safe. And the venous malformation joining Dandy's vein up here on the tentorium. And so forth. So there's the post-op view. I'm getting a little short on time. I'm just going to show you maybe one more case. This is a medullary brainstem cavmal, brainstem cavmal grade of 4. I'm going to do this through a far lateral approach. And here are the films. You can see it comes to the surface on the lateral side of the medulla. So I'm going to want to come laterally in this direction. There was too much tissue here on the floor of the fourth ventricle for me to go transventricularly. So I decided to go lateral, but it creates a problem. If I'm coming in this way through the far lateral approach, the axis of the lesion is actually into the medulla, so it makes it a bit more challenging, and you're going to see that now in this video. This is the far lateral exposure. The cerebellum is up here. The spinal cord is down here. This is the condyle that's been removed. This is the inferior petrosal vein that I'm dividing. And I'm going to get myself into this vago-accessory triangle where you can see this discoloration of the olive. And remember, the axis of the lesion is actually into the medulla medially. So I've really got to start looking this direction here, which means moving my body position to the right and trying to see as medial as possible, which I think that was the challenge in this case, was to have this kind of a view, but to be working the lesion out from this hidden place more medially. So let me just go forward. This was one that was removed piecemeal. You can see how I'm having to pull portions of the lesion into my working corridor from the medial side. It's coming out piecemeal here, but you can see that by working those planes and constantly trying to maximize my view, I can see it all. This shadow over here is my hand. I'm up against the condyle. I can't go any further lateral to look medial. So my instruments in my hand are getting in the way a little bit. But you can see here the gliotic planes are coming into view. And I'm able to finally get around this thing and get it all out. So here in the end, a nice clean resection cavity. Here's an overview showing pica, the lateral medulla, the far lateral exposure, and how lateral you have to shift in order to see into that small working space. And here's the post-op. So let me jump ahead now and finish up because I think we're out of time. I'll spare you the last few cases, but I just want to make a couple of closing remarks. You know, when we think about surgery of the brainstem, there are many approaches. I've shown you some of these for the midbrain. I showed you the orbitozygomatic transsylvian. I showed you the contralateral transcallosal transchoroidal approach. And I also showed you this, actually that's on the next slide. I showed you the contralateral supracerebellar, but you can see there are many choices that you have here to reach the midbrain. And it really requires careful study to see where the lesion comes to the surface and how best to line up your trajectory with the lesion's access. In the pons, again, a lot of choices listed here. These check marks are the workhorses. I showed you the transmiddle cerebellar peduncle approach. The trans CP angle approach is another variation of that. This transventricular approach is a real workhorse. I did not show you that one, but I think we're all familiar with that one. And I didn't also show you this transpontomedullary sulcus approach. That's another beautiful approach that we published on years ago that is really valuable for inferiorly, anteriorly located pontine lesions. The list for the medulla is a lot shorter. These are either the transventricular approach or the far lateral approach. But again, you can see that a lot of different choices, the choices and decisions you make really affect the outcome. So to wrap this up, you know, I'll say this: patient selection is the secret. So I would really encourage you to use that brainstem cavernous malformation grading system that we've developed. I think it's very valuable. Look for where the lesion comes to the surface. Choose your approach and your entry zone very safely. And then, you know, I think there's a really fine line that we walk between complete resection and getting the job done and going too far and causing morbidity. So I think that's just something we have to always bear in mind with these cases. So with that, I am going to exit and stop my screen share and turn this back over to you. Thank you.
Thank you, Dr. Lawton. And Sam, it's all yours, Sam.
Yes, I am here.
Okay.
Professor Yuha, are you here, sir?
Okay, I'm sorry. I got confused.
Okay. Professor Yuha will start our discussion about this lecture. Thank you,
Thank you,
Professor,
Michael. It was
thank you, Professor Lawton, for this magnificent work and for accepting our invitation. Thank you.
You're welcome. Thank you
It's
for having
yours, Professor Yuha.
Thank you, Michael Lawton. Thank you, Michael, very much for wonderful lecture. It was full of excellent surgical thinking, wonderful illustration to learn, and very good surgical technique. So I learned a lot. Coming from a small country, we cannot get so many that kind of cases. So I really learned a lot. And the beautiful illustration and the great photos of the surgical techniques, videos, so you could operate with you. It was a very good experience. I thank you very much, and I appreciate very much. So I think everyone following this lecture.
Thank you.
Very much. And one thing I didn't see in your list, you are not using subtemporal approach.
Yeah, I'm not a huge fan of the subtemporal approach. It's certainly a useful approach for lateral midbrain lesions, going under the temporal lobe, cutting the tent. It's I think a popular one. I find on these webinars lately, more people are using that approach than I would have thought. I've just never been a fan of how much temporal lobe retraction you have to do to get down to the tentorium and work through that hole. And plus, the other approaches work so nicely. The gravity, the addition of gravity to some of those other approaches that go transtentorially from below really makes them so nice to work with. I think people have a natural reluctance to do sitting position and to work from so far away from the lesion. But the combination of trajectory and gravity really make some of those other approaches really nice.
I totally agree. I like to have sitting position. I could introduce even in China that in resistance of many anesthesists, we could make it, and I like to do in sitting position. But subtemporal, I think is the very good approach. You have to have some tricks, not destroy the temporal lobe, spinal, lumbar drainage and so, but I have found it very useful, especially in brainstem cavernomas, because it gives very simple approach, and of course also sitting position. So otherwise I can only say that I learned a lot.
Thank you, Juha.
Thank you. Thank you.
Okay, now we will take questions from panelists. Please unmute yourself and ask your question freely.
But there is one question from Dr. Abhiram. He was asking Professor Lawton if a subchoroidal approach is good enough rather than interpharyngeal approach for the interthalamic cavernoma.
Yeah, I think it's important that we get our terminology really clear. There are basically three approaches that we need to talk about. One is the interfornical approach, which I did not show you. The other is the transchoroidal approach, which is lateral to the fornix. And then the third is the subchoroidal, which is actually lateral to the choroid plexus. And so each one is progressively more lateral. And I've not been a fan of the interfornical approach because it's a lot of manipulation on both fornices. And I really don't like to risk a memory deficit in my patient. They can be really devastating or really life-altering. So I've shied away from the interfornicele approach. The transchoroidal fissure approach is nice because the anatomy really opens well when you follow the venous anatomy and mobilize that anatomy laterally. The subchoroidal approach is nice. I have a beautiful case I could have shown you, but I use that when lesions are a little bit more laterally. The choroid plexus adds an additional layer of protection between you and the fornix. And so going subchoroidally or lateral to the choroid plexus can be protective of the fornix, but it does do some funny things to the anatomy. It makes you work within the venous angle. You have the opening of the foramen of Monroe, you have the opening of the subchoroidal space, but then you have the thalamostriate vein running in between. So it does limit you a little bit, but for selected cases, it's fine. And I think you can make your choice between those three.
Mike, can I ask you one question? Mike, I want to know, yeah.
Always ask me questions.
Mike, what, obviously cavernomas have to be removed completely. There is no question. Suppose in a postoperative situation, you find a small amount of cavernoma left behind. You will like to go again, or what would you like to do?
Yeah, it's a great question. I am a believer that if you're going to do this surgery right, you have to do curative resection, 100%. And if you see remnant postoperatively on your films, then I take patients back. If for some reason, there's reason not to try and take that last bit because it's so eloquent, or because maybe the patient just refuses the surgery, then there are those cases where I don't. But usually taking them back to the OR in the perioperative period is very straightforward. It's very instructive for us as surgeons to do that. You'll see from me a paper, it's in press right now, on my experience with residual brainstem cavernous malformations. We had 14 out of about 200 and some odd. So it does happen. And I think when you're trying to walk that fine line between taking it all and not hurting the patient, we are at risk for leaving a little bit. But my residual rate was around 5%. It was 6% early, it dropped to 4% later. And I think, it's almost impossible to get that to zero, because sometimes if you push too hard in the brainstem, you can hurt people. And you also have the problem of corners, or blind spots, as I call them, where you're looking down a long corridor and you can't see around those spaces. And, it's easy to miss a little bit. So it's going to happen.
Another thing, what you didn't touch in your lecture, maybe I want to know about some venous situation, venous anomalies or large veins around the cavernoma.
Yeah,
and
well,
how you handle, what is your thinking process in those cases?
Yeah, so it's a great question. I think some of the dogma around venous malformations is that you have to preserve them and you can't sacrifice them. And I completely agree. I think you have to preserve them. But I think it's also important to remember that the venous malformation is a caput medusa, meaning it's got a trunk, which is like my wrist, and it's got the snakes or the branches. And it's okay to take a branch up here. You just can't violate the trunk. I think when you violate the trunk and you close off that venous flow, that's when you get complications. But to get the malformation fully resected when there's a finger right around it, I think that's okay to do. And I think it's important to make that differentiation. That's what allows you to get these curative resections that we were just talking about. But again, preservation of the trunk is key. And I think there was one video in particular where I had to dissect a lot along the vein just to get it mobile and work around it. And I think those are the kinds of steps you have to take. And the other thing I would say is that Dr. Spetzler used to say that there's always a venous malformation, 100% of the time. And I think that's probably not the case. It's probably not 100%, but it's really high. It's probably 75% of the cases. So you have to be on the lookout for it.
Thank you, Mike.
How often have you seen a re-hemorrhage in these residual lesions? Rebleeds in the...
Yeah, well, I think it's quite common. In fact, most of the time, that's how these recurrences present, or at least convince you that they're real. Sometimes you'll see them immediately. Sometimes you'll see them at 3 months or 3 years. But when you have that, it's unmistakable that you've got a residual that's left behind. And I think their bleed rate in our review in that paper I was mentioning was about the same as what their baseline rate is. So even though you've taken a very large malformation and reduced it to just a tiny little remnant, it bleeds at the same frequency. So, that's another reason to be aggressive on there.
Dr. Lawton, can I ask you a question?
Yeah.
Yeah. So you didn't also show transventricular approaches because you do it very, very, very rarely. A transfourth ventricular approach to pontine or medullary cavernomas. Do you do it very rarely?
No, I didn't show it, not because I don't do it very rarely. It's because I think all of us are so familiar with that. I don't have a lot to teach because it's a simple suboccipital. You split the tonsils, you go up through the vallecula, you expose the floor of the fourth. So I think all of us know that. That's probably the easiest of all of these brainstem approaches, but it's a workhorse. I use it all the time.
Thank you, Sir, for your magnificent lecture. Please stay with us till the end of session, I hope, because there are a lot of questions for you. But we have to shift to our next speaker. Thank you.
Thank you.
Please, thank you. Please, Professor Manis, we will shift to our next speaker, Professor Amir Dahshti.
Yeah, thank you, Dr. Hassan. The next talk is on management of complex AVMs, and we have Professor Amir from Chairman and Director of North Shore Hospital, and he to speak on complex management of complex AVM. He has trained himself under Professor Tribole at Switzerland, but then he has done 2 fellowships in skull base and cerebrovascular, and has been practicing both skull base and cerebrovascular for many years, and has published more than 100 papers and has given more than 250 invited lectures. His main interest is on bypass and managing aneurysms and AVMs. Without wasting time, I'll like to request Professor Amir to give us the pulse of thought on how to manage unruptured grade 3 brain AVMs.
Thank you very much. Really an honor to be here, see a lot of great colleagues and friends. I'm very happy to see Atul, Juha, and Michael, and all other friends and colleagues who are on panel. And I'm again very honored to be here to share my experience on complex brain AVMs. Just please tell me if what do you see right now? You see me or you see my screen?
We see your screen, but you need to change to...
there we go.
Yeah.
Perfect.
Is it good? Okay, thank you. I would like to speak about a subgroup of brain AVMs that probably are the one with the most ambiguity in our community, which would be unruptured grade 3 and maybe some grade 4 AVMs. And these are the ones that probably some neurologists would clearly suggest a conservative management based on recent trials. And obviously, these are the AVMs where the risk probably is more significant compared to the lower grade AVMs. Look at this 27-year-old female who was diagnosed with some headache, no seizure, normal neurological exam, platelet number at 1,000. She had an ITP, and she has this very complex left frontal AVM. It's quite anterior, but as you can see, the size is significant, and supplies by both MCA and ACA territory. Relatively diffuse nidus when you look at the lateral aspect of this AVM. The question is, what should we do for this lady, 27-year-old? If you go with any trials that we have seen recently, clearly the answer is, well, she's totally asymptomatic. Headaches, really, we cannot say the headaches is really related. The headaches are not debilitating, so leave her alone. Is that the right answer? If this patient comes to my office, which was the case, am I doing the right thing for a 27-year-old with an AVM of this size and this configuration? And another one, completely asymptomatic patient. This actually happened to be the cousin of my own secretary. Callosal AVM, 27-year-old, and normal exam, and this callosal AVM with deep venous drainage toward the vein of Galen. So what is the right option? And you can see this AVM is very complex. It's compact, but has significant features that if you go with some feature of hemorrhage, there is intranidal aneurysm, there is stenosis of the venous drainage, and so on. If you look at the grade 3, and Dr. Lawton has really stratified that, and we know that this grade is very inhomogeneous. There are some that are 3- or those with lower risk, but the higher risk grade 3 potentially can have a surgical related risk of up to 14 or 15%. And also, if you look into another type of grading, which is the supplementary grading for AVMs, and if you look into age, whether they are ruptured or unruptured, whether the AVM nidus is compact or diffuse, these are all features that add to the classical Spessler-Martin grading, and we can further stratify what grade 3 AVM can potentially have a higher risk of bleed. But at the end of the day, at least in my practice, I have dealt with all grade 3 with the same philosophy, but just by stratifying the risk and relaying that to the patient and family that some of them might be more risky. Now, again, I don't want to talk about, I have a whole 1-hour talk on Aruba, and I don't want to talk about that, but it's a study that completely, as far as I'm concerned, fails to give us a guidance about AVM grade 3. Because there are lots of issues with this study, although it's on the paper seems to be a very nice study, very well executed in terms of the methodological aspect of it. But if you dig into it, and we don't have time to do that today, the method used for treatment, the evaluation of treatment efficacy by modality per number of cases has issues. There is a selection biases, there is a short follow-up, although there is a recent study that shows a longer follow-up, but still, I have concern about every aspect of in this study in terms of giving really the patient with unruptured AVM an advice that, well, you know, we should not treat them because Aruba showed that the risk of treatment is higher. And quite frankly, if you look at this study, only 5% of patients had pure surgery, and just below 20% had surgery. While in my opinion, in the opinion of many of my colleague open vascular surgeons, the treatment of brain AVMs is mainly surgery. And anything else is an adjunct treatment. And embolization is great, and radiosurgery is great for some cases. But if you look at Aruba, surgical resection, which should be the mainstay treatment for AVM, is not really there. It's like a less than 20%. There are lots of criticism. Again, you can read by yourself about the randomization, comparison to surgery that is irrelevant, and high incomplete obliteration rate. The same way that we were discussing about cavernous malformation, an AVM that is not completely eradicated. There's irrelevant to talk about the outcome or results because that's not the goal with surgery. Our goal is to completely resect the AVM. And also we can talk about the surgical expertise of the group involved in Aruba and so on. So at the same time, I think all these randomizations are good because that raise the bar for us. There is an apparent overestimation of surgical risk. You look at ISAT, you look at COS, you look at Aruba. Every single randomized study has shown significant surgical risk. which I think if you just select those very experienced center, you will see that the risks are less in those experienced center. So there is apparent overestimation of surgical risk because that's done in many, many different centers. But this randomized trial will force us to improve our quality of care, to improve and raise the bar, and ultimately improve current surgical outcomes in everything, in brain aneurysm surgery, in cavernous malformation surgery, in bypass surgery, and in AVM. Now we look back and look like this is coming from Dr. Morgan's series on grade 3 AVMs, and you can see in experienced center, you have some, of course, some complications, but the results are very reasonable. And you can see that those with bad outcome are 3.6%. Another study done with our friends in Toronto and shows that the patients who were assigned to surgical treatment at the Toronto Western Hospital, similar to those that were entered to Aruba, have better outcome compared to Aruba. So there is something to say about a complexity of interpretation of the Aruba results and implying that to a day-to-day management of the patient with brain AVM. It's not possible. And that's why I have to say that Aruba has not impacted our practice. As a matter of fact, our number of AVMs are going up. Last year in our institution, I'm not the only one doing, I do most of the brain AVM surgery, but I'm not the only one. We have the largest department in neurosurgery in New York. And last year, we, in our whole neuroscience department, the service line of neurosurgery, we have done 43 brain AVM surgery. So this has been the highest number compared to the previous years. So Aruba has not affected really the practice of AVM in our group. Now, if you look at the risk factor for hemorrhage, these are all, you can read by yourself, depending on the study that you read, these are the risks. If there is a prior hemorrhage, obviously, this is the highest risk, but all other factors that are mentioned here could potentially be an additional risk for hemorrhage. The most important take-home point would be the presence of intranidal aneurysm. Intranidal aneurysm, or even a very close prenidal aneurysm, can double almost the risk of hemorrhage for an AVM. So an AVM that is unruptured, based on Aruba, has about 2% risk of rupture. But some other studies have shown, like from this one, coming from Toronto, the annual risk of bleed could be up to 4.6%. And I know from Helsinki and the epidemiological study done when Professor Ernest Niemi was in Helsinki, clearly had shown that the risk hovers anywhere between 2 to 4%. And obviously, there are some additional risk factors, like deep AVM potentially can have a higher risk of rupture. So we have to put all these things together. It's very difficult to just come up with one sentence of conclusion that what AVM should be treated. Every AVM has a different characteristic and has to be selectively evaluated. Now, if you look at the Christian Staff, a study that was published many years ago, is a beautiful study and shows actually that, as a matter of fact, the simplest AVM, the AVM unruptured that are superficial, no history of hemorrhage, and no deep venous drainage, has the lowest risk of rupture, 0.9%. So these are the AVM probably that will be okay, leave them alone. But at the same time, these are the AVM that the risk of surgery almost close to, I wouldn't say zero, but is extremely low. And when we get to more complex AVM, which is grade 3, we will see that the risk of natural history goes up. So that's further emphasized that this AVM should be even taken care of with more degree of attention and aggressiveness as opposed to easier or smaller AVMs. Now we have advances in surgery. I'm a fan of preoperative onyx embolization. As a matter of fact, now I am also learning and doing endovascular. And I have to say, by doing endovascular treatment, that have improved my surgical skill set in terms of surgical resection of the AVM, because I understand an AVM better. The amount of time that we spend going through each pedicle to embolize an AVM will also significantly enhance the intraoperative understanding of the 3D anatomy and microsurgical anatomy of an AVM. Awake craniotomy could be helpful for AVM. ICG video angiography is helpful. This is a paper we published a few years ago. In some cases, could be very helpful to give you at the glance initially before we're starting the resection, how the AVM is draining, what is draining vein, what is artery, because sometimes it's difficult to recognize a feeder compared to a draining vein at the very beginning, specifically if you're dealing with the larger AVMs. Surgery in the angio suite is very important. All our AVM surgery in the past 7-8 years, we do them in our hybrid suite. All of them get intraoperative angiogram to confirm that the AVM is fully resected before taking the patient out of the operating room. And there are technical aspects, use of non-stick bipolars or a must. Navigation is very important. And now for the past year or so, we use augmented reality to further enhance the understanding intraoperatively. And obviously the post-op care in the neuro ICU is very important. This is our hybrid suite. As you can see, it's a Zigo room. We have one flat panel and as you can see, the X-ray arm that is easily mobile. And when we do the surgery, within few minutes, we have the endovascular team ready to do the intraoperative angiogram. And if there is a residual, the head is open. Within few minutes, we are back with a microscope. And I think this is important. I think in 2020, every center of excellence should do the AVM surgery. And as a matter of fact, every single aneurysm or AVM surgery in this kind of setting. Now, and this is what we published a few years ago about the importance of intraoperative high quality angiogram during neurovascular surgeries. Now, going back to this patient, we did some workup. We improved her thrombocytopenia. And we tried to embolize this with onyx, but this was such a high flow AVM that would not allow a complete or better embolization. And as a matter of fact, one of the vein got occluded during embolization and the other vein almost partially. So at this point, we stopped the, I was called into the angio suite when the second vein was almost getting occluded. And it was, the goal was whether to go to the kill with an endovascular treatment and try to close the vein and the whole thing probably, or just to stop and go for surgery, which is obviously what I decided. You can see here, this AVM was approached from the left side. So this is a right-handed patient. There is an ACOM aneurysm that you can see here. Please just confirm to me that you see the video running.
Yeah, we can see the video running, though.
Very good, thank you.
It is running.
So this is the left frontal region, and you can see this AVM is extensive, just anterior to Broca, is not involved in the Broca region. So we get around this AVM nidus, separate the nidus from the feeders, and getting around it, you can see here one of the deep venous drainage that I leave alone for now, and I just get around the AVM nidus. And by the way, these bipolars that you see, they are not stick bipolars, but I use almost 100% of the time now these stick bipolars. And you can see here, this is the fox, the medial extension of the resection. We get to the deep feeders of the AVM. We get around the nidus, disconnecting from the ACA feeders and MCA feeders. And this is what we get at the end with complete resection of the nidus. And that's the remnant of the draining vein. And look in, specifically in this large AVM, is important to look into the surgical cavity. As you had always mentioned, go and touch the bottom of the surgical field and make sure that there is no bleeding. If you get bleeding after AVM resection, that means that you have a micronidus probably left behind. And this patient did not turn a hair. You can see this is post-surgery, a complete resection of the AVM. Now, quite frankly, I think this patient is much better served at 28-year-old with this angiogram intact and with no AVM compared to leaving her alone with the natural history of the AVM. And the same for this one. I'm not going to go through this video. This I did the surgery a few years ago. For some reason, I don't have the video. And this was the callosal AVMs looks very scary and complex. But when you get to them through I have another one I'm going to show. When you get through them, the identification of the anatomy becomes relatively straightforward once you expose them. So what we did in this case, just going and separating the ACA en passage vessels from those that are going to the nidus and achieve the results that you can see on the right side and the picture below with complete exclusion. This patient had some cognitive issue after surgery, but this was a few years ago. She's completely back to normal. This patient, as I said, was a cousin of my own secretary, and she's doing very well post-surgery. Now, this is a young woman, 22-year-old, with supraorbital headaches, and you can see that there is an AVM in the Sylvian fissure region, and there is also an AVM in the basial frontal lobe. And the angiogram shows this weird aspect of the two distinct AVM. One is in the Sylvian fissure, and one is around the region of the gyrus rectus. This patient does not have hereditary telangiectasia. We did the test for that because that's the first thing that we should rule out when you see multiple AVMs. And because of the location, this patient is right-handed. I took this patient for surgery. You can see from the right side injection, you can see that the left frontabasal AVM is fed by ipsilateral and contralateral artery of Hübner. And when we check here, we took this patient for surgery in awake condition, and you can see the location of the this AVM is just at the level of the ascending ramus. So very close, not in the Broca, but very close. And that's why I decided to take this patient awake. And the surgery was done while we can have a neuropsychologist in the room. And here opening the Sylvian fissure, talking with the patient. And before starting to resection, we stimulate, make sure that resection of that segment of the brain AVM is not causing any speech arrest. You can see those are lots of vessels, normal vessels, but this is the only one that is going to the nidus. Many of them are en passage vessels. And then we get around, I stimulate behind, make sure that the speech does not get affected by a resection. Obviously, we have to stay very close to the nidus of the AVM. And this patient tolerated the wake surgery very well. And we are getting around the nidus. Obviously, we have to stay very limited around the nidus, specifically posteriorly, because it's sitting on the Broca region. And this part is removed. And then for the frontabasal part, I put the patient into sleep. Basically, we didn't need her collaboration in terms of speech and remove that part, continued the surgery to remove the other part. And this is intra-op and actually 1 year post-op angiogram showing complete exclusion. And this patient for now is cured, but she's 22 with 2 AVMs. She definitely needs long-term follow-ups. And this is her post-op CAT scans. Another one, a young patient, 36 with seizure, right-sided numbness. And you can see an AVM, which is almost in the Wernicke area on the left side. We did functional MRI, shows there are some activity close to the AVM, not exactly on the spot of the AVM, but close enough that when I decided for surgery on this, I decided to do it awake. Again, some preoperative embolization was done to decrease to some extent the supply. This patient gets supply from both MCA and PCA. And this surgery is done again awake. Now, one could ask, what is the advantage of doing it awake? Would you stop the surgery if the patient has a speech arrest? And the answer is the main reason to do the surgery awake first is to map the location of the AVM. And yes, if clearly you know from the get-go that you're going to cause a significant aphasia, one option is to stop the surgery. You can close and find other alternatives. And the other also is that when you go subcortical, and this is what we are doing here, we are going subcortical, and then we continue to stimulate in a subcortical fashion. And that if we see that the stimulation causes speech arrest, to stay as close as possible to the nidus. And we can basically be as selective as possible. The awake craniotomy give you a further degree of security that you keep the patient's speech intact. And I know that Michael Lawton has also published a couple of cases where he interrupted the blood supply to the AVM in an eloquent region, but then he left the AVM alone for radiosurgery, considering the fact that further resection could have been risky. Here we can see we get to the deep part of the AVM, the patient is awake, she starts to cough, we get some additional bleeding, and I'm trying really to stay very close because I lose the speech on the patient. She can't really collaborate at this point. So that's why the surgery sometimes for this larger AVM doing awake becomes more complicated, but we can get around it and control. And that's what you can see at the end with complete resection of this AVM. The most important point here is that this patient had a thalamic syndrome after surgery with no stroke, but a thalamic syndrome, hemisensory deficit that she had before and a pain, almost like a Desjardins-Roussi syndrome. with no stroke in the thalamus and improved after 2 years, but she was not happy with it. So I have to acknowledge that I caused her this syndrome for about 2 years. She was pretty miserable with that pain, syndrome, but no neurological deficit. And this is our initial experience that I had done 5 patients with awake, and we have done a couple after that. Now there is another patient, another young patient with a large AVM, posterior aspect of the temporal lobe, and you can see in this one, the functional MRI was not very successful because you can see activity all over the places. And look at this AVM, the venous varices, the significance of the venous drainage superficially and deep to the central venous system. And you can see the vein of Labbé in this patient is completely draining in a retrograde fashion. So the vein of Labbé in this patient has become completely dysfunctional. So again, this is a complex AVM. This is, I categorize that a grade 3, but depending on how, you size this AVM, if you consider all the, you can get almost just above, it's not getting above 6 centimeters really, it's between 3 and 6, but it's a high grade 3 AVM in an eloquent location, although it's pretty posterior on the temporal slope on the dominant side. We did an embolization. This patient also has a significant external supply to this AVM, as you can see through the middle meningeal branches. So we embolized 1 session, the external supply, and then we embolized 2 sessions separately, the supplies from the PCA. Every time that we embolize, we do not want to embolize more than 20-25% of the nidus, because otherwise there is a significant risk of edema, specifically with onyx, or hemorrhage. And once this 2 was done, there was still a significant portion of the AVM, as you can see, alive. And this patient, obviously, I didn't take him awake. This is the left side. Temporal base is on the top of the picture. And you can see the draining vein, and we're getting around the nidus of the AVM. And you can see here that this AVM is very extensive. All the MCA feeders remained alive. I didn't want to embolize them because those are easy to get at surgery, so we don't need to take a risk with embolization. And we get around this AVM. But what I would like to show you here, after about a couple of hours into dissection of this nidus, and you can see the posterior draining vein, and you can see here is a major venous pouch posteriorly. And we are getting around the nidus, separating the nidus in more deeper region. You can see all these deep parenchymal feeders that have to be one by one coagulated and cut. And you can see how easily they can rupture and cause trouble. So obviously this is a tedious surgery, it's a very large AVM. And here I try to disconnect the AVM from the posterior draining vein just to mobilize it better, because I would get to the limits. And you can see just touching that venous pouch, despite having done several hours of dissection, you see still a significant amount of pressure into this AVM with the rupture of the vein during the surgery that we had to tamponade, and I had to just keep going around the nidus without taking that posterior vein, because the nidus could not tolerate the exclusion of that vein, which I tested with the clip before taking it. And now further continuation of the resection. And you can see finally we get to the deep part, to the basically hidden part of the AVM, which is the medial part. And now gradually get one of the draining vein now. And you're getting, this is the medial surface. This is the part that has been onyxed. You can see this is the feeders from PCA, and we get to the ventricle here. This is the entrance to the ventricular extension of the AVM. Very significant feeders from the ventricular region, choroidal feeders, the most dangerous ones. And then this is what we get at the end with complete resection of the nidus. And this is the post-op, intra-op angio and post-op. And this patient also did not turn her, did very well, no neurological deficit and no visual deficit. And this is his post-op CAT scan. Sylvian AVMs could be very challenging. This is also a patient who present with seizure, has been known for this AVM, which is a fronto-opercular Sylvian, very complex because 2 MCA vessels are going to the nidus and coming out as en passage. And I decided for surgery for this patient, a young patient, symptomatic by seizure. Obviously, Sylvian Fisher AVMs are complex, but again, like callosal AVM, once you explore them and once you understand the anatomy, and as long as we understand what is en passage and what is direct feeders, we will then be able to separate and skeletonize the nidus from the normal vessel. So you can see this AVM is dead center in the sylvian fissure on the frontal side. According to Sujita classification, this is a frontal front, or basically this is a medial type sylvian AVM. And we also did a functional MRI. The motor activity is behind it, but obviously here we're talking about the sylvian fissure. So all these vessels in the surgical cavity are eloquent vessels. We're not talking really about the parenchyma itself, but the vessels are eloquent because you can't afford sacrificing or losing any of those vessels. So here is a right pterional craniotomy. Obviously, we do that under monitoring. So this is a 3D picture. Please look at the picture on the left only. This is the dissection is being carried out around the nidus. You can see the draining vein going anteriorly toward the sylvian fissure. The nidus is being dissected away from both the frontal operculum and the temporal operculum. Some part of the nidus that is embolized is seen here. I'm looking for identification of en passage vessels. And here you can see that after further dissection in the sylvian fissure, I can find the direct feeders. These are direct feeders from MCA to the nidus. And those can be taken, obviously. You can see the draining vein gradually getting a little bit bluer, but it's still reddish. Dissection is carried out on the frontal operculum side now, getting all the feeders around the nidus. And separation of the nidus from the parenchyma. This is the direct feeders. And you can see here, we can get around. Now we get on the temporal operculum. So you see the vein is still pretty robust and pretty red. This is the feeders that are coming from the other side, which is on the temporal side. And now we identify the normal MCA vessels here. You have to make sure that normal MCA vessels remain intact. And you can see here, these are the dissection separation of the MCA normal vessels from the lower part after separating all the feeders to the nidus. So the MCA calendura remains intact. These are the last feeder to the nidus. And here is nice because when I get these last feeders and I rotate the AVM, that draining vein that was red suddenly becomes blue. You can see here, this is the draining vein, and these are the last attachments. And again, you can see here deeper toward the insular feeders from the other MCA branch, more posteriorly and more medially. And further resection around. Again, another en passage vessel here. Meticulous separation of the AVM from the brain parenchyma and stay as close as possible to the AVM nidus. And here you can see the draining vein is completely blue. And then in this particular case, I elected to just put a clip, wet clip on it, but usually just coagulation is enough. And this is the nidus out. And this patient did very well with no neurological deficit and complete resection of her AVM. I can show the picture here. I cannot skip the video. So next case is a subpericallosal AVM. As you can see in the patient who had a ruptured from a lenticulostriate aneurysm. If you look at the bottom left picture, is a right MCA aneurysm on the M1. The patient had a subarachnoid hemorrhage, and this AVM was sort of diagnosed incidentally, and we decided to treat at a later time. And the approach that I chose for that was a contralateral transfalsing. So this is coming from the right side, contralateral. This, you see the fox, and you see the bottom of the interhemispheric fissure. You see the ACA feeders here. And that approach advantages, we immediately get the exposure to the feeders. And also we are not dealing with the draining vein that is going up on the side of the AVM. We are able to have an unobstructed view through the contralateral hemisphere. Here we see the feeders going to the nidus. And at this point, I get the main feeder going to the nidus. In this case, I don't need to really cut the falx because this AVM is really low, really inferior. And you can see this is the extension of the AVM around the corpus callosum. And again, there are unpassage vessels, identifying the vessels that are going to the nidus compared to vessels that are continuing as normal, like this one, this ACA here. And then once this anatomy becomes clear, and this is a matter of just getting around the nidus and separate it from parenchyma, because we have already obstructed the direct feeders to the nidus from ACA. And its ACA itself is en passage. And this actually, I did this case without any preoperative embolization because it's relatively smaller nidus. And that's what you can see here. We get around, separate the nidus from the brain parenchymoid. Corpus callosum is here. And with the contralateral exposure, the advantage is that the lateral aspect of the extension of the AVM becomes easier because there is no need for retraction of ipsilateral brain parenchyma. And just getting around it, I'm going to speed this up. And this is what we get at the end with separation of the nidus. And last bit of connection to one of the previously coagulated feeders or vein. And this is what we have at the end with complete resection of the nidus. As you can see, the nidus is here. And we did not have any change in the monitoring. You can see the brain retraction is only with the PADI, no subtendon retractor, and a complete resection, as you can see on these pictures. Now, so this idea of going contralateral, we just published that recently, our experience. I know Dr. Lawton has published that before, and it's very good for AVM which have an extension that goes beyond 2 to 2.5 centimeters, like this one. Like an AVM in a young patient with left deep parietal AVM, as you can see, significant draining vein toward the vein of Galien. And you can see the nidus here. And for this AVM as well, the best way, in my opinion, considering the deep aspect of this AVM, and you can see how robust it is, coming ipsilateral is difficult. In terms of getting access to the lateral aspect is fed also by some choroidal branches from the PCA and branches from the anterior artery. So this is going contralateral with the right side down. AVM is on the left side. Here we have to cut the fox because the AVM is higher than the previous case. And you can see that gives you an unobstructed view of the contralateral hemisphere. And the good thing about, and here I'm cutting the inferior sagittal sinus, which can be cut with impunity. And that will allow complete exposure of the lowest part of the parietal parasagittal lobe. And then we see the onyx, because this AVM was embolized before. You can see here the onyx demarcation of the nidus. And we're getting around the nidus here. Separation of the nidus from the parenchyma. There are feeders from contralateral PCA, which basically would be the right PCA that are not taken care of by embolization, but I will find them here during this dissection. Here we can see, we'll get around separation again. This is the feeders from the ipsilateral on my side PCA, and that will be taken care of readily. We separate this nidus millimeter by millimeter from the parenchyma. Now we are on the contralateral side, on the lateral aspect of the AVM, and you can see there is a very nice oblique view at it that if I had come from ipsilateral side would have been much more difficult. And basically getting around the nidus. This is a complex AVM, extension, significant extension anteroposteriorly. And basically separating. These are last deep parenchymal feeders. And you can see even until the last one has been taken care of, they still bleed very profusely if we don't coagulate them appropriately. And sometimes, you know, as a surgeon, you get tired. You might not spend enough time on one compared to others. And when they bleed, they are pretty robust. And this part is done, and then it's just me to speed up that. Just a matter of taking your time. And this is a clip on the draining vein that going toward the basal vein of Rosenthal. and still another feeders, deep parenchymal feeders, before I completely disconnect this nidus here. And this is what we get at the end. I'm cutting this draining vein, and this is what we have at the end with complete resection of the AVM. This vein was preserved, and the AVM was fully resected. The patient did have a little bit of a foot drop after surgery for about 6 weeks, but after that, she improved completely. Now, not all of this AVM should be done contralateral. For this one, for instance, I mean, this one actually I did contralateral as well. I'm not going to show the video because of the lateral extension on the picture in the middle. You see it was just above 2.5 centimeter. I prefer to do that. But if you look at, let's skip this one. But if you look at this one, this is higher up, it's high frontal. This can also be done ipsilateral. And this AVM you can see, I elected to do this ipsilateral. This is also a picture from Dr. Lawton's publication that he had also elected on this type of case to do them ipsilateral. I think you can go either way, but you can see even on if you go ipsilateral, you still can get a good view as long as they are not going too much lateral. So I just want to show you the exposure that you can get through the ipsilateral interhemispheric fissure. This is the draining vein. This is after the embolization. And this is the separation of the nidus. Again, these parasagittal AVMs are very important. And it's important to identify the feeders that are going to the nidus compared to the feeders that are coming from the en passage vessels and the en passage vessels itself. So here, after some evaluation, I elect that this vessel is directly going to the nidus, so we can take it, but the branch below it is not going to the nidus, so we have to preserve that. And that may take some time, but once you identify that, the rest becomes readily understandable, and we can just get around the nidus. All the blood supply from the medial side are gone, and then we just get around the nidus. It's a matter of resecting this almost like a tumor after once the blood supply has been taken care of, except for deep parenchymal feeders. And this is what we get at the end. This is just an example of ipsilateral approach. So let me see how much time I have. Maybe I can show 2 more cases. This is interesting. This is a hypocampic AVM in a young patient who presented with seizure. And you can see that this AVM is fed mainly by anterior choroidal artery, but has also feeders from the PCA, and is deep, as going to the vein of Rosenthal and then back to the basal vein of Rosenthal. So again, please just look at one of the picture here because this is a 3D video. Look at the picture on the left. I decided to treat that with a transsylvian, translumen insula exposure, the same way we do for amygdalohypocampectomy in a selective fashion. This is a full opening of the sylvian fissure, identification of the carotid artery, and the PCOM and choroidal that is going. So here we can see this is that robust choroidal in its cisternal segment. Obviously, we can't sacrifice this here. So once I identify the feeders from the choroidal, then I remove the uncus and I decide to go translumen insulae. But when we check with the navigation, we see that the lumen insulae does not get me enough posterior. Here is the lumen insula. It doesn't give me enough posterior. So then the decision was changed, and I decided to go transcortical, transchoroidal fissure to be able to get to that posterior part of the AVM. Otherwise, you can see here, this is the lumen insula. But when I check with the navigation, I see that I leave probably a ½ centimeter of AVM behind. So that's why I switched the technique and go transcortical, transchoroidal fissure. You see here, we get into the choroidal fissure, and that will allow us to get to the posterior part of the nidus. Now we have a control anteriorly, we have a control posteriorly, and I identify the PCA feeder right there, as you can see. And once we have that, we have complete full blood supply control. This AVM was not embolized because of the risk of embolization with regard to anterior choroidal artery. And then this is the anterior choroidal artery that can be clipped only at its plexal segment. That has to be way distal right there, that I put the clip on the plexal segment. And then we already coagulated the feeders from PCA. And then we will, this is feeders from PCA, and then we get around the nidus, and the rest would be just separation of the nidus from the rest of the hypocamp. And you can see here, this is the nidus is coming out. And this is a post-op picture, and you can see we published that. This is the choroidal artery is fully preserved. and the AVM is gone. And this patient has had already two follow-up, 1 year and I think 3 years, and they are stable. So we don't, this is a young patient, 22-year-old, so she probably needs to have another follow-up in 10 years. Occipital AVMs are challenging. I think I published this paper 10 years ago. It's probably the largest series of occipital AVMs. The problem with those unruptured occipital AVM is the risk of causing hemianopia. And you can see in this paper, we had a 17% risk of new hemianopia. This patient of mine did not have a hemianopia. But as you can see, this AVM is at the bottom of the occipital lobe and just in the lingual gyrus, not in the calcarine sulci. And we decided to do surgery for her. She was very anxious. She had some visual symptom without hemianopia. And you can see this is post-op. I gave her a hemianopia transient, but after that, she improved to almost a normal vision. And finally, I'm going to close the presentation with this last case. There are lots of posterior fossa AVM, but this is, I think, a nice one, an unruptured AVM in the superior cerebellar peduncle and causing tinnitus. A patient who has the feeders from SCA going to the superior cerebellar peduncle AVM and draining to this cerebellar hemispheric vein and coming down to the transverse sinus. The best approach for this would be an extreme lateral supracerebellar, as you can see in this illustration. It does give a direct view on the AVM. It's a little bit shallow and narrow, but that's the best way, direct shot on the AVM itself. Many people would say, well, why don't we gamma knife this? Yes, I mean, it could be. It's not very big. It's about 2.2 centimeters. But I think with the right surgical approach, we can cure this AVM. And embolization could be helpful potentially, but I think the size here was not very big, so I just elected for direct surgical resection. Again, this is a 3D video. Please look at one of the picture. This is the CP angle explored on the left side. We can also do this in the sitting position. I do a lot of surgery specifically for acoustic and sitting position, but this one is on a lateral position. And you can see this transverse sinus has been completely exposed. This way will allow an unobstructed view, mainly for the light. And you can see we get to the superior cerebellar peduncle area. We have the check the navigation with heads-up display to make sure that we are exactly at the location of the nidus. Again, here we have superior cerebellar artery that gives en passage vessels going to the normal cerebellum and giving direct feeders to the nidus. So this is important to identify. You see, there is a traffic of lots of vessels, not all going to the nidus. We have to identify which one is helpful. And actually, the ICG sometimes is helpful, and I did an ICG here. And then here, I'm checking with the Doppler to see if there is any difference in the flow. And once I identify which one is going to the nidus, I get that one. This is the normal SCA here. You can see the fourth nerve, as Dr. Lawton showed in his supracerebellar transtentorial approach. And I know that this AVM is all below the fourth nerve. We are in the superior cerebellar peduncle. And then we get around this nidus. Once the feeders from SCA is gone, then the AVM has only a little supply from the parenchyma around it. And resection in the SCP is relatively safe as long as you don't get to the dentaric nucleus. We just submitted our experience with the AVM in the SCP location. I have several of those done in the past few years, and we have had very good outcomes. And so I think these SCP AVMs that are not brainstem AVM are a different entity, and surgery is, in my opinion, the best option for them. And you can see we can get around this nidus and separate from the rest of the superior cerebellar peduncle, just behind the mesencephalon, and AVM will be resected. And this is what we get at the end. You can see here, and this is the view at the end. Even the petrosal vein or vein of Danby was preserved. A supracerebellar approach. And again, that can very nicely be done in the sitting position as well. And this is a post-op with preservation of the SCA. This patient's tinnitus, ironically, did not improve, but at least she does not have the AVM anymore. So when I look at my personal experience over the past few years, and again, these are cases that I have done, the cases that has been under my direction alone. I have helped my colleagues for AVM surgery. We do way more surgery than the numbers that I have. But these are my personal patients that I have followed, and I have the database for them. You can see it's all different locations. And if you look at the characteristic, more than half are unruptured. And many of them are grade 3, which is my really a topic of interest, because I think these AVMs are the AVMs that have the ambiguity in terms of their decision making in our society. And there are new neurological deficits. You can see the unruptured one, we have had 9, and in the ruptured one, I have had 11 new neurological deficits. Some of them are 2 deficits in one patient. But you can see the only mortality was in the patient in a very bad, this is a hemorrhagic patient, a grade 4, who succumbed to the complication, not necessarily to surgical resection, but the post-operative period of septicemia and a cirrhotic patient, etc. But the surgery itself can cause neurological deficit, as you can see, but many of those deficits improve with time. And as a matter of fact, if the AVM is resected completely and we can achieve a cure for a potentially a fatal or significant problem on a given patient, I think it's important to consider the treatment of brain AVMs in selected cases. And here we can see we have had residual, overall 4% residual, but the number of residual has gone down since the few years ago that I used the angio suite, because we will continue to resect the nidus until the AVM shows complete resection. And if we need to do, some of my cases, I have done 2 or 3 intraoperative angiogram until we have confirmed that the AVM is completely resected. Now, there is sometimes a bias, because sometimes even you might have a clean angiogram and then a year later you have a residual. That's a different story. And that's why the number gets higher than 1% in total. So I think that we cannot give a uniform paradigm to treatment of unruptured brain AVMs. There's no question that these AVMs should be treated in centers of excellence when there is expertise. And I think a vast majority of grade 3 and some very carefully selected grade 4 AVM should be assessed individually and considered for treatment. And I think at the end of the day, the patient will do better with 0 risk of hemorrhage compared to the natural history of this brain AVM that all of us know could be very significant and unfortunately sometimes fatal. Thank you very much. And I hope I was on time.
Thank you. Yeah, you're right on time. And thank you, Professor Amir, for giving a very clear picture of how to make a decision of surgery in grade 3 AVMs. There are many questions for you. And
I'm sharing my screen.
Yeah.
Okay.
There's a question from there's one question that if you have speech arrest while operating, and then what do you do when you're doing an awake craniotomy?
So as I mentioned, there's 2 main reasons to do awake for AVM. One is that before even starting the resection, you map the region. And if you see that right on the AVM, the first thing I do, I put the stimulator on the AVM itself, 10 milliampere. If on the AVM itself, you get a clear speech arrest, which has never happened so far. But if it happens, I assume that I would be very uncomfortable. Let's say on that young 22-year-old college student patient who is doing psychology. If I get a speech arrest by stimulating on the nidus, I think probably I would have backed out and say, okay, this AVM should not be resected. So that's give you a very important information. I think that's one thing. And the second thing is that specifically on the subcortical, if you get speech arrest, and depends how significant the speech arrest is, you can stay as close as possible to the nidus. We always stay as close as possible to the nidus, but sometimes there is a little bit of a breach into the parenchyma to get those deep feeders. And we have to be more careful, and we have to be more closer to the nidus. We obviously make the surgery a little bit more difficult, but these are the 2 information that we use from the awake craniotomy. These are the 2 that I have used. The third would be, if you feel that you get a speech arrest during a resection, you have disconnected the AVM partially and potentially have made it a better candidate for response to radiosurgery if you feel that further continuation of the resection can cause a permanent speech deficit. This has not been my experience, but as I mentioned during my talk, this also could potentially be an indication that you not know until you do the surgery. And then that potentially that patient will go undergo gamma knife or any type of stereotactic radius surgery. And considering the fact that the AVM has been devascularized, probably would have a better response rate.
So how often you had to back out because of a speech arrest during surgery?
I have not. As I said, this has not been my experience. I have done a wake surgery for AVM only. The paper, I think, had 4 patients, and I have done 2 after 6 patients. So we have not. And also, these are cases that are sort of on the gray zone. In cases that I have done functional MRI before, and I know based on the functional MRI that there is about 5 millimeter or so of distance or more of the functional activity and the nidus. So we already going with the knowledge that most likely the immediate brain parenchyma adjacent to the AVM nidus is not eloquent. So we are already biased by knowing this information. So none of the cases that I have done, we have backed out, but I'm ready to back out on a AVM where when I stimulate on the nidus, and if you're in the Broca area, the patient has a speech arrest, then I will not do it.
Yeah, thank you. Thank you, Professor Amir. There are other 2 basic questions that what do you do if during the initial part of surgery, if the draining vein is ruptures?
Well, that can happen because sometimes, during exposure, some patient might have a stuck dura, specifically on hemispheric. It doesn't happen for like those contralateral exposure, stuff like that, because you're away from the venous drainage, but for convexity can happen. If this is only one venous drainage and there are other venous drainage, most likely the patient can tolerate that because there is other type of drainage until you get around the nidus. But if you sacrifice the sole draining vein before getting to the AVM, we have to basically do what we call it a commando resection, in the sense that you got to go and resect it as soon as possible. Probably you will deal with a brain AVM that is very brittle, probably with the brain AVM that it's very engorged, and every time you touch around it, it's going to bleed. So I can remember one case that during the opening we injured the draining vein, or actually 2 cases that I can remember over the past 10 years. But one of them was not significant problem because we were able to just tamponade the situation and get around. But if that's the sole draining vein, then you have to quickly resect it. So basically the goal would be safe resection as quick as possible.
Okay, Amir, can I make some comments, please?
Sure.
Yes, sir.
Amir,
So
that was a great
comment. Please answer one of the question where one of the young listeners asked, how do you identify a feeding artery and an end passage vessel? How do you differentiate? Just give a comment on that also, sir.
I'm sorry, how to identify en passage vessel? Is that the question?
Yeah.
Well, first of all, I think the most important thing before going for surgery for AVM is an extremely careful review of the 3D AVM angiography, and now 4D even, but 3D at least. So you will understand before going for any AVM surgery. That's the way I learned. I remember when I was during my training and fellowship with whoever I was working, we would go in the angio suite and turn this AVM multiple times to really understand what are those vessels. So when I go to surgery for AVM, I clearly have a clear idea of what is the 3D anatomy. So everything that I see almost all of the time is something that I expect to see. So I kind of know where the en passage vessel should be and the feeder is going from to the nidus. Now, sometimes it's difficult to distinguish with them. So ICG can help sometimes because you can see how the vessel is connecting to the nidus itself. Or sometimes it's just a matter of further dissection. Don't take any vessel, dissect around the AVM in the subarachnoid space, because en passage vessels are in the subarachnoid space. So you don't need to resect the AVM. Dissect very widely and split the subarachnoid space until you fully expose the harboring vessels, and you can see immediately what is the vessel that continues behind the AVM and what is going to the nidus. So it takes some experience and some basically judgment intraoperatively, but that's what needs to be done. And now with augmented reality, we can also identify those vessels. We can segment the en passage vessels. And if you have using the augmented reality during the surgery, we just did that. We can put that vessel into your basically microscope heads-up display, and that will show you that en passage vessel you were looking for is this one. But I would not rely only on that. I think that would be just an additional way of confirming your surgical understanding.
Yeah, Amir,
Thank you,
that
Professor
was
Amir, and I'll
a
request Professor
great
Goel to-
presentation and some wonderful cases, as you know, and as the young people who are watching must know that AVM surgery is not easy. AVM surgery is not, you need very extensive experience, very heavy planning, and absolutely perfect execution. Means there is nothing more difficult in neurosurgery in selecting your case, planning your issue, and then doing the case. And what I will say, Ahmed, you have shown some great cases, but unfortunately, you have not been able to deliver the difficulties that are involved in treating these cases. What can be the bleeding issue, how the bleeding can affect, how the small vessels can bleed, how the big vessels can bleed, how you control the bleeding during operation, how you control the deep feeders, how you control the ventricular feeders, how you avoid the veins. I think it would have been quite, informative, particularly from a person who has quite a good experience to deliver a message as to what were the main issues of difficulty in these AVMs. That is one issue. Second thing is, as regards the contralateral approach, you may not know, but this approach I had described some 28 or 29 years ago. And I used to do quite frequently this contralateral approach, but over the period I have realized that even for parafalcine AVMs and relatively deep near to the edge of the Fox AVMs are better to remove from the ipsilateral side rather than, angulating your microscope and going to the hemisphere, coming underneath the superior parietal sinus. I have a feeling that ipsilateral approach is a better approach for these kind of AVMs over the period I have realized. So these are the two things which I wanted to tell you.
Thank you, Atul. First of all, so nice to see you here. Last time we met in Bombay and we felt that we're gonna see each other in the next meeting, but we don't know when it's going to be. Very nice to see you.
No, you have got a great collection of cases and a formidable collection of cases. And you are still, you have a long time to go and run with these cases. And I'm sure after several years, you will be a power-packed figure in this AVM surgery. There is no question. With your enthusiasm, the way you are talking, the positiveness in your attitude, this is what is required for an AVM surgeon. And I'm very happy and glad to see that attitude in you.
Thank you very much. Regarding your first comment, obviously I showed some of those bleeding. I didn't want to insist on it. And as you saw, probably I speed up some of those videos, but in those videos, there are difficulty and challenges controlling those deep parenchymal feeders. I just maybe showed a glimpse, but I agree with you. I should have probably shown them a little bit more for everyone to realize that it's just not coming out just like this. And it's a struggle. And some of those AVM cases has been several hours. It's not a 1 hour, 2 hour surgery. There are complex surgeries. So I did not mean by any way or shape to simplify or underestimate the complexity of anything we do, specifically complex AVMs. And with regard to your second criticism, I think the main reason for me to go contralateral would be really the lateral extension of the AVM. And the other thing would be when you have to go too far lateral, and obviously you have a significant experience and you have gone through this and come back to basically the basic. I think the other issue is that when we have to retract the ipsilateral lobe just to get to the lateral part, and if the draining vein are in your way, and if, let's say, if this is the only draining vein, that might be an obstacle. But again, this is really surgeon's preference. And I think you are right, because you have done both, and then now you feel that it's probably better to go from the ipsilateral. This way you don't put in risk the contralateral hemisphere.
You know what, Amir, just let me stop you. You know what I do now? I have a bilateral exposure. So I come early in the operation from the contralateral side, get to the feeders, and then once I've got a reasonable hold on the AVM, I come from the ipsilateral side. So bilateral exposure is a good option in such a situation. So you can have the advantages of both the sides.
Point well taken.
Very good. I mean,
can I ask a question to both of
your
you?
presentation.
Thank you.
Can I ask a question to both of you, both Professor Goel and Professor Amir? If there is radiosurgery is given to AVM in a Broca's area, what happens 3 years down the lane?
I mean, you're asking about, is a general question. Obviously, for an AVM to be amenable to radiosurgery, you need certain criteria. I have to say, I have been, and I do also gamma knife for AVM. So some, I would say over every year, probably there are 5 to 7 AVM that I radiate, if not more. And for a variety of reasons, could be not necessarily because they are in eloquent location. I think the results are pretty good. The AVMs are small, and sometimes the results are unbelievably good after even less than 3 years. There is a risk of about, I would say, 5 to 8% of peri-AVM nidus swelling, which can cause some dysphagia, yes, but I think that risk is remains still relatively minimal. I think gamma knife is safe. Dr. Atul, what do you think?
See, the thing is, you know what, Amir, as you said, you know, when you have an AVM where the stakes are very high. You see, stakes are so high that if you remove the AVM, the patient is almost unchanged. But on the other hand, if you create a complication, like you create speech deficit, you create hemiplegia, you absolutely create a devastation. So stakes are absolutely high. It is and the message, another message that must be given is that you have to be not half sure or a little bit sure nothing will happen or this will happen. Because if something happens, it is huge. Because it is not a glioblastoma that if something happens, in any case, something would have happened. But here it is a benign issue. And if you create a speech deficit, if you create a major deficit, it remains with the patient. And then there will be issues and the patients and relatives will not be able to handle that. And they will come back to you. So it is very important to be absolutely sure during the operation, before the operation, that we will be safe. Of course, nothing is safe in neurosurgery and nothing is less than dangerous in neurosurgery. We have to take the risk and we have to weigh our experience and our technical abilities. But the stakes are absolutely high and dangerous. And we have to be absolutely careful. And end passage vessel, you see, that is the main issue in AVM. You cannot just take one normal vessel. You take one normal vessel and you create a devastation. So we have to be absolute in this. And that is the reason why not many people in the world are giving this kind of presentation. How many people? Not even 15 people can give because of the dangers involved. But this surgery is there here to stay because the results, if you can do a good operation, you cure the person and you cure the symptoms and you give new life. The thing is whether you can take it or whether you cannot take it. That is the issue.
Thank you, Professor Amir. And because with a short of time, we'll ask all the people to send their questions in chat box, and it will be answered. Will be sent in the email. We'll go to the next question. I'll request Professor Paritos to introduce Dr. Sarath Chandra.
Good evening. I'm Dr. Paritosh from Bangalore, and it is my great pleasure to introduce my ex-teacher, mentor, and a great neurosurgeon from India, Dr. Sharat Chandra. He is a professor at All India Institute of Medical Sciences, New Delhi, and he wears many, many hats. He has deep interest in epilepsy, skull base, neurovascular surgery, CV junction, spine surgery, and most importantly these days, he's editing the premier journal of neurosurgery, Neurology India, which is the premier journal of neurosurgery and neurology, which is published by Neurological Society of India. So without much ado, I invite Dr. Sharat to speak on one of his favorite topics, which is transciliary keyhole approach to anterior circulation aneurysms. Dr. Sharat, please.
Thank you very much, Paritosh, for that introduction. It's truly a great pleasure and honor for me to be here in this EWNC forum, and I thank Professor Sameh Morsali for giving me this invitation, and also for the entire committee members for having considered me for this very nice, informative, and lucid forum. So I would be describing here my own little variant of supraorbital keyhole approach for clipping ruptured anterior circulation aneurysms. And this I have been doing for the past 1 decade, even though it doesn't constitute a majority of my surgical strategies for aneurysms. It constitutes approximately 15% of all the strategies that I use for aneurysm clipping, but still I find it that it's a very effective technique of clipping anterior circulation aneurysms. So we all know that T-renal craniotomy is a gold standard, but it does have certain disadvantages. The main thing I feel is that we are making too big an opening to tackle too small a target, and that has been one of the main criticisms, and because of which Professor Perniske has developed the technique of keyhole approach for clipping aneurysms. Now, my technique is something which consists of both the frontal bone as well as the orbital roof. So in that sense, it's a true base of skull base approach, and practically there is no frontal lobe retraction. And I feel that it's the shortest approach to the anterior circulation aneurysms. So in that context, I would like to call it not keyhole, because I know there is certain reservations from certain group of traditional neurosurgeons in being called keyhole because you're compromising the approach to that particular target, but I would call it as optimally invasive. Now, in our approach, we do a small fronto-orbital flap. That's the first step. And secondly, we drill the inner part of the frontal bone so that we are able to provide adequate retractor, and we are able to provide this true triangular cone in order to approach the target. In addition, we have also been using it to drill the clinoid process extradurally, in order to approach the IC aneurysms, which I would be showing in one of my videos. So drilling the frontal lobe provides approximately 30% more space, which almost converts it into a mini T-renal craniotomy-like approach. So the selection of cases, so ideally it's for unruptured aneurysms, but getting unruptured aneurysms in our situation is uncommon because most of the patients come with ruptured aneurysms. So if aneurysms are ruptured, the kind of aneurysms which I prefer to use this approach would be wide patients who would have wide cisternal spaces or relaxed brain. And my suggestion is that one should start doing this for initially small to moderate size aneurysms. And as you get comfortable in your learning curve, you could go on for treating more bigger aneurysms. Initially, I would advise to avoid any complex anatomy. And once you're confident, you can go in for more complex aneurysms. While there is no true contraindication for any type of anterior circulation aneurysms, but everything depends upon the comfort of the surgeon. And it's very important to maintain a nice learning curve without having too much of morbidity. Some of the contraindications include presence of a tense brain. Now, large frontal sinuses are relative contraindications, but if the patient does have large frontal sinuses, then perhaps in some cases I would avoid it. So are similarly large aneurysms or those having fetal circulations. But again, I have clipped many aneurysms with fetal PCOM circulations. One word of caution in trying to approach the extreme laterally placed MC aneurysms, as these aneurysms are too close to the bone and sometimes could be a challenge to be accessed through through this kind of approach. So this is the kind of incision we give, and currently I prefer to give incisions through the eyebrow, and I like to keep it slightly on the upper part because it can otherwise lead to some amount of ptosis. And it's important to preserve the supraorbital nerve, avoid injury to the frontalis nerve, preserve the periosteum. It's also important to give the incision parallel to the skin follicles so that we avoid any amount of skin loss. And it's also important to note the presence of the temporofacial branch, which is just 2 centimeters behind the eyebrow. So the commonest way by which this gets involved is when we use the fish hooks for traction. So if this traction is too much while you're doing the exposure, this can lead to a neuropraxia of this nerve. So these are the steps, and I will actually show it to you in a video, but this is how the exposure looks like. And after closure, if the patient comes after some time, we can hardly make out any kind of skin incision. And a properly given infraciliary incision with a mini frontoorbital approach can provide excellent cosmetic outcome. And here I will show you a few videos. So this has a bit of music. I hope you won't mind it. Are you able to hear this?
Yes, Dr. Shah. Yes.
This is a 45-year-old female who has presented with subarachnoid hemorrhage, and angiography showed an ACOM aneurysm filling from the right side. As you can see that the mini frontoorbital craniotomy through an eyebrow is a true base of skull approach, giving the shortest possible route to clip the aneurysm. I use a number 15 blade to give the skin incision. The position of the right supraorbital artery is marked before the surgery is started. I prefer not to use monopolar at all. Hence, my entire exposure is done by bipolar and by sharp dissection. So that is the key burr hole which is being exposed. Periosteal elevator is used to retract the periosteum. It is very important to use this to carefully dissect the periorbita from the bone. And you can see I performed the entire skin exposure under the microscope. It's very important to position the fish hooks so that the optimal exposure can be given. So as you can see, I prefer 1 fish hook inferiorly and 2 fish hooks superiorly. As you can see, I use the bipolar only to perform all the soft tissue dissection. So one can use a molecular resonance bipolar with a high cutting mode, and this functions an excellent tissue cutting device. The periorbita is very carefully separated from the inferior surface of the orbit. I next take an AM8, which is a cutting drill, to perform a burr hole at the key point. So the burr hole should be fashioned in such a manner so that both the dura as well as part of periorbita is exposed. Next, a B1 Midas is taken and a cut is made from the inferior orbital margin from the lateral side till it joins the orbital roof. I use the periosteal elevator to perform the cut over the orbit. The B1 is now taken to perform a small craniotomy, which runs from lateral to medial till it reaches inferiorly up to the level of orbital rim. The last part of orbital rim at the level of orbital roof may be cut using a periosteal elevator again. The flap is now elevated carefully to ensure that there are no dural tears. Small pieces of bone on the posterior part of orbital roof may be removed and can be replaced back at the end. It's important to suture back any minor tears in periorbita to prevent any severe orbital swelling. Now at this stage, it's very important to optimize exposure. And for this reason, I take a diamond cutting drill and drill the inner table of the frontal bone. This increases exposure by almost 30% without actually increasing the size of the craniotomy. As you can see in this diagram, the upper diagram shows the mechanism by which the frontoorbital flap is removed in toto. And by drilling the inner table of the frontal bone, you are able to achieve the maximum possible exposure. Hence, from an opening of about 3 centimeters, a very good opening can be created. The dura is open now. It's very common to see brain up to the surface of the dura. This is not brain swelling. The magnification is increased at this point. A retractor is placed inferiorly and laterally, and the CSF is let out from the Sylvian cistern. This is usually enough to make the brain significantly lax. For some reason, if the brain doesn't become too much lax, the brain now can be retracted superiorly, and some more CSF can be removed from the medial part of the Sylvian cistern as well as from the optic cistern. So this is how the brain looks normally once the CSF is let out. And as you can see, it provides a very comfortable exposure to go ahead with the surgery. So this is a traditional view which we see under microscope. So one can now very nicely visualize the optic nerve. So the optic cistern is now being exposed. The exposure is being carried laterally. And as it is carried laterally, one can see the ICA coming into view. So the optico-carotid cistern is opened generously, and it's very important to carefully work around this area so that the exposure is optimized. This is one of the key steps in aneurysm surgery, which maximizes the exposure. And one should patiently work around opening each and every cistern so that the CSF is let out completely. The arachnoid lateral to the optic nerve, the carotid artery is now cut. So one can now visualize the right A1 coming medially. I almost always prefer to undertake a gyrus rectus approach. So I cauterize the portion of the frontal lobe just medial to the optic olfactory tract and open up the frontal lobe at this stage. So going through the brain preserves all the blood vessels, and in this case one can see that the Huebner's has been very nicely preserved because we were able to undergo the gyrus rectus approach. So once the dissection is proceeded more distally, the aneurysm now comes into view. So that's the olfactory tract. So that's preserved. And that's the gyrus rectus, which has been opened medial to that. So the aneurysm now comes very nicely into the view. So the A1 is exposed completely, and one can see the Huebners arising from the distal part of the A1 and going in a retrograde manner. A ball dissector is passed both medially and laterally so as to define the neck of the aneurysm properly. That's the opposite optic nerve, which can be seen now, and the opposite A1. So once the neck is defined, one has two things, two strategies. There are two strategies which a person can undertake at this time. So one can put a direct permanent clip and then proceed with the dissection, or one can put a temporary clip and then define the neck of the aneurysm. I generally prefer to put a permanent clip at this stage because the neck of the aneurysm was very nicely defined. So once I place the permanent clip, the fundus of the aneurysm is now dissected and exposed completely so that the tips of the clip may now be exposed. So it's very important to perform all this dissection under high magnifications so that any vessels which is there on the opposite side, as in this case, should be very carefully preserved. So over here, it can be seen that the clip has slightly taken over the opposite A1. So there was a bit of dilemma at this stage. So I thought that I could place one more clip more distally and remove the proximal clip. But what happened was that there was a tear at the neck of the aneurysm. So when I tried to remove the proximal clip, there was bleeding because there was a rent at the neck of aneurysm. So that's a really dangerous situation. So what I did was I removed the proximal clip, and using the suction to suck off any bleeding, I gently let go of the clip and readjusted it more distally. So now the tip of the clip is safely away from the A1. Now at the end, I always prefer to do a third ventriculostomy so that adequate CSF can be let out from the ventricles. So I believe that any kind of it reduces any kind of incidence of hydrocephalus. So this is how it looks at the end of surgery. The brain is very lax. And we have done the surgery just through an opening of 3 centimeters. And that's the post-op. We close subcuticularly. And as you can see, that's how it looks on CT scan on day 1 post-operative day. So as you can see, this is a moderate size aneurysm at the level of the ICA. And you can also see the anterior choroidal very close to the neck of the aneurysm. Now this is a short video recording which I have taken for another patient. Now we go directly to the aneurysmal exposure. Here we see the optic nerve, the ICA, and the aneurysm on the lateral side. Now we can identify all the structures. The second nerve, the ICA, the atheromatous plaque, the anterior choroidal artery, and the aneurysm. So over here, I'm applying a temporary clip proximally on the ICA, supraclinoid ICA. The aneurysm is now dissected both along with using a ball dissectors, both medially and laterally, and a permanent clip is being applied. So here you can see that the permanent clip has taken up the anterior choroidal artery. So I release the blades of the permanent clip
and shift it very gently laterally so that the anterior choroidal artery becomes visible. So now you can see that the anterior choroidal artery is preserved. The temporary clip on the ICA is now removed. The ICA is retracted laterally, and one can now visualize the anterior choroidal artery, which is intact. The arachnoid, which you see deeper to the anterior choroidal artery, is the Lilliquist membrane. So zooming out the microscope, now you can appreciate the exposure. So using the ICG, once again, we confirm that the anterior choroidal is intact. It's very important because that's the reason why we have done surgery here, as the patient was not too suitable for embolization because of the proximity of the neck of the artery of the aneurysm to the anterior choroidal artery. And now one can very nicely visualize the anterior choroidal artery. So I prefer to put a gel foam soaked in papaverine to prevent any vasospasm of the perforators. The dura should be closed watertight with glue, and the skin is closed subcuticularly. The third case which I'm going to show you is about a clipping of an M1 aneurysm through a keyhole. Actually, M1 aneurysms are most closely placed to the eyebrow incision. And one of the contraindications, relative contraindications, is if the aneurysm is very, very laterally placed. As you can see in this diagram, M1 aneurysms are closest to this approach. But obviously anything distal to M1 bifurcation and MCA bifurcation is not indicated through this approach. Now, this is a patient who's had an M1 trunk aneurysm which was looking somewhat complex, obviously could not be coiled. So this is the approach. So we are retracting the brain a little more laterally. And as I've already mentioned you, the sphenoid ridge has to be drilled much more than what it can be conventionally. So in this case, we are going from proximal to distal because it's a complex aneurysm. And as you can see, we have exposed the ICA as well as the optic nerve. And now we are cauterizing the proximal part of the Sillen fissure, the cortex over the Sillen fissure. I prefer to cauterize it and then expose the Sillen fissure rather than trying to expose it directly, as I find that this is much more easier to do. And now at this point, you can see that there is a small lobule which is getting exposed. So obviously this is not the main aneurysm. It is more of a bulge from the M1. So I cauterize it, refashion it, and now I'm applying a temporary clip on the M1. And I try to apply a permanent clip without taking up the perforator which is next to it. And that's the clipping of the small aneurysm. Now the main aneurysm, as you can see, is buried within the substance of the brain and is pointing in a posterior and a superior direction. And you can see that now it comes into view. And in this approach, you can very well appreciate that it looks as if you're clipping it through a T-renal approach only. So applying a permanent clip. So that's the clip which is now applied. Now I cauterize and shrink the aneurysm and removing the temporary clip. So this is an example of a complex fusiform ACOM aneurysm in a 14-year-old child because of vascular dysplasia. And that's the opening and that's the post-op. So I'll show you a short clip on how this was done. So you can see that there is a whole bulbous swelling of the entire ACOM complex, which is pointing away from you. So it's important to pass the perpendicular fenestrated clips in such a manner so that it is away and you are able to reconstruct the entire ACOM. That shows the tip has passed through the aneurysm. So once you get confidence in tackling smaller aneurysms, you could also start tackling more complex aneurysms. And that's the post-op, which shows the approach to it. Now, this was a 34-year-old pediatrician who came with a ruptured aneurysm who had a large IC aneurysm 10 days after ictus. And in this case, we used the fronto-orbital FSOCA not only to make the flap, but also drill the Clinot process extradurally. And that's the two perpendicular clips which has been used to secure the aneurysm. And this is post-op. And I'll show you a short video on how it was done intraoperatively. So there was a small dural rent and this was repaired at the end. And this is drilling the inner table of the frontal bone. So earlier I used to use a cutting drill for drilling the frontal bone, but that may not be a good idea because bleeding is difficult to control. So best is to use a diamond drill. And now I'm using the drill to drill the Clinot process extradurally through the transorbital axis. So I'll just hasten that. So now dissecting the ICA and the aneurysm now slowly comes into the view. So one can see the majority of the aneurysm which is bulging under the optic now. That's the subarachnoid hemorrhage.
So here the ICA has to be reconstructed by passing the perpendicular fenestrated clip behind the aneurysm. And the reconstruction has to be performed very patiently. So a single application is not enough. You have to apply and release it and apply and release it multiple of times. So there's a little bit of cleaner process which was left, a small bit, which could be easily drilled from inside. Majority was drilled transorbitally. So as and when the dissection proceeds, there is a drainage of CSF, the space goes on increasing. And that's the beauty of plasticity of brain. So after some time, you feel as if you're doing through a turinol. You don't get a feeling that you're doing through a very limited or small opening, because basically that's the amount of space you require to do the surgery. That's the bifurcation of the ICA. So we applied a clip in the neck and then another one distally. And now we are trying to fashion the aneurysm and secure the fashion the IC and secure the aneurysm using perpendicular clips, fenestrated clips. So as you can see, it requires the clips. So you have to patiently close it and open it so that you make the vessel wall malleable and you're able to reconstruct the ICA properly. So single application is to be discouraged. You have to keep on closing it and opening it multiple times in order to recreate the ICA. I'll take it fast forward. So that's the end of surgery where we have recreated the entire. Oh, sorry about it. So there was a calcific nodule in front, atherosclerotic calcific nodule. We tried to secure it, but then it was not contributing to any portion of aneurysm, and we left it alone. And one can see that the tips of clips has gone well beyond the aneurysm, and the ICA has been satisfactorily reconstructed. So I tried putting a small clip, but it didn't work out. And that's the size of the craniotomy. Now this is an example of a large dysplastic truncal aneurysm, and it's actually a giant superior hypophyseal aneurysm. And there was an intraop rupture in this case, and the video shows how we've been able to tackle the intraop rupture. I'll skip the initial craniotomy and again drilling the Clinoid process extradurally through the transorbital route. That's aneurysm coming into view. I'll just take it forward. That's the rupture. So obviously the temporary clip was not effective and the whole thing gets filled with blood. But the bottom line is you handle rupture in exactly the same way, because for your excursions, for your movement excursions, you don't require so much of space. You think you do, but actually don't. So I remove, and then that. So there was an initial rupture, so it was a difficult aneurysm. So I tried to pass a perpendicular fenestrated clip. And then I have a massive rupture again. And I think that was a mistake. So again, I was closing and opening the blades so that I was able to fashion out and then slowly oppose the ends of the aneurysm. And the mistake here was I did not define the proximal part of the aneurysm. So I tried to blindly pass the tip of I think it should come here. Yeah. So I still see aneurysm there, and while I was trying to define the proximal part, oops, that's it. So again, there was a rupture because the tips of aneurysm blades did not go significantly to secure the aneurysm. So this is completely unedited video. There's absolutely no additions here. So it shows what actually was going on. Use a suction over the rupture point. Do not use any cotton. Do not use any gel foam. Keep the suction directly at the point of rupture. Define the point of rupture. And the rent is usually very small. It's not a major rent. That's it. And if you can see, if you keep the suction over a period of time, the flow of blood reduces. So I had passed the clip almost 70 or 80%, and there was a little bit of sac which was left. So I advanced the clip so that I close the rent and the rupture is controlled. Now I'm able to visualize the proximal part completely. So that's the end of surgery. So remove the temporary clips. So this is a short video of a left PCOM aneurysm with a fetal artery. So that's the. So I'll just come to the end where we show how we can preserve the fetal PCOM while clipping the aneurysm, which is important because when you're clipping the PCOM, especially when it's a fetal, a posterior communicating artery, you need to preserve it. So define both ends of the aneurysm. Planning to go for, now you have to separate the fetal PCOM using the blades of the aneurysm and you have to ensure that the blades pass just over the neck of the aneurysm. And then you can see that the fetal PCOM is preserved over there. So that's the end of surgery. So doing this procedure forms approximately 15% of all my cases. So till date, I have clipped about 94 aneurysms. And this is the distribution of aneurysms. Now, if you look at the logistics in terms as compared to TRN, those operated through TRNL approach versus the SOCA approach. The size obviously was smaller for or larger for the TRNL approach, and the operating time, the clipping operating time was less for the SOCA approach, and the blood loss was also less. These are the complications. They were comparable between both the TRNL craniotomy as well as through the SOCA approach. So the main problem related to this technique, I would say, is because you're doing it for being minimally invasive. So you have to be careful and diligent when you're doing the surgery. So if you're not, you can produce a disastrous result like this. So this exposure was done by my resident. So it can come about if you're not careful in your dissection, if you use cautery. And that's the reason I prefer to do all the cases using microscope. No cautery whatsoever. Extreme care while dissecting the orbital sheath from the root and complete hemostasis. Similarly, when you're exposing the orbit, you should not use any drill on the orbit because it can injure the Muller's nerve and again can lead to ptosis. So the orbit has to be, orbit or the periorbiter has to be very carefully preserved. The other problem is obviously the temporary neuropraxia of the facial nerve, which happens because of injury to the by the traction, and this is how it can present. So generally in most of the cases we found that this is temporary and it improves over a period of time. Now I've already spoken about contraindications, but generally as of today I would not use it for giant aneurysms, especially which are anterior pointing. Similarly, not for poor grade aneurysms with severe edema or anteriorly pointing ecom aneurysms, especially with the fundus attached to the planum. Now, these are aneurysms which are dangerous because moment you try to retract the frontal lobe, there could be a rupture of the aneurysms. Similarly, extreme laterally placed MC aneurysms are also a contraindication because of the difficulty of access to it. But the most important is that one should keep a smooth learning curve in order to avoid complications and also loss of confidence. And the progress has to be comfortable as per the surgeon. The advantage is obviously that it's optimally invasive. I wouldn't even call it minimally invasive. It's optimally invasive because it provides the just amount of space what you require while preserving the cosmosis of a minimally invasive approach. It's almost, the space created is almost that of a TRNL approach in terms of the target approach match. So once you zoom in the microscope, you won't feel much of difference. And because you're including the orbit also, frontal bone and the orbit also, there is no restriction in terms of movement to your instruments. In our experience, it's been cosmetically aesthetic. Patient feels that it's a small surgery and it adds to the confidence of the patient. And of course, the advantage is that for IC aneurysms, you can also do extradural drilling of anticlinoid process for clipping of ICS supraclinoid aneurysms. Pitfalls, of course, is the learning curve and also getting used to the psychology of operating within smaller spaces. So thank you very much. I think I've completed just in time.
Great. Thank you very much, Dr. Sharath, for this fantastic lecture and very, very good things. We will take some questions. One of the question is, what are the indications when you apply permanent clip directly rather than just doing a temporary clip and then apply permanent clip? And a related question is, how do you do it? Either you first dissect the neck and apply permanent clip and then dissect the fundus. That is
Yes.
the question.
So the ratio of usage between temporary and permanent clip depends on the experience of the surgeon. So when you start off initially, you tend to apply a lot of temporary clips because you want to avoid accidents, and that is good. But later on, as you gain more and more confidence, you prefer to apply permanent clips directly. But I'm not saying that when you apply permanent clip, that's going to be the permanent application. You could always apply permanent clip, continue with the dissection, and then readjust the permanent clip. And that's the way I prefer to do surgery right now. Now, in case of PCOM, there it's kind of challenge to actually dissect the PCOM from the aneurysm, especially if it's a fetal PCOM. So the best way I find is that you open the clip and pass one of the flanges of the clip in between the aneurysm and the fetal PCOM. And that forms an excellent dissecting device, as I was showing in one of my videos.
Amit asks, what is one of the most terrible experience you have had via this approach, if any?
Yeah. So the terrible experience obviously is a rupture. So when you have a rupture, there is an initial decapitation. So you get an initial sense of apprehension of fear, and then you get over it. And in fact, in the series I've showed you, 22% of all my patients have a routine intraoperative rupture. So the only thing is you should be able to be in a position to control the rupture. So one should not push in any cotton or gel foam or any kind of external devices. So you can take the suction, directly keep it over the point of rupture, and you'll be able to define the point of rupture. And using the other hand, you should be able to readjust the clips. So that's the fundamental point on how to handle the intraoperative ruptures. So I find this much better than cases where you don't remove the orbital roof, because moment you remove the orbital roof and make a frontal flap, don't have bony boundaries all around. So you get enough space for movement of all your instruments. And in terms of cosmetic outcome, it gives a similar cosmetic outcome. I mean, I've not found any difference in that, except that in this, you have to do the dissection properly. You have to be very meticulous when you're exposing the periorbita, and you should not damage the molars now.
One question from me, Dr. Sharath. If somebody is starting out from this approach and shifting from pterional approach, what would you think would be the first few aneurysms that they should do with this approach?
So the best type of aneurysms to be clipped by this is ACOM aneurysms. So that's very nice to be clipped. And then you could go in for MC aneurysms, which are really close. And then you can go in for PCOM aneurysms. So this is the ratio I would advise. But while clipping MC aneurysms, a word of caution that extreme laterally placed MC aneurysms are not accessible. So one should study the CT angio very carefully before you tackle the extreme laterally placed aneurysms.
Right.
And then again, the progress has to be as per your comfort. So as you keep on doing aneurysms, you'll know which you can do through this approach and which you can do pterional. And my personal suggestion is, every time if you don't do it, do this just for the sake of doing it. Because even in my experience of close to 1,000 cases, only 15% of these cases I have done this kind of approach. So you will always get a sense of gut feeling. You'll get always a sense of feeling whether you would like to do this approach or not. And that's how you should progress.
Yeah.
And
Because can I ask a question?
Yeah.
Yeah. Dr. Sarath, you said 22% of the time you had an intra rupture.
That's right.
So, yeah. So when you did a pterional craniotomy or a mini craniotomy, your incidence of intra rupture was similar or different?
So my experience of intra rupture was that when I started doing aneurysms, my incidence of intra rupture was very less. Now, as my experience increased, the incidence of, paradoxically, the incidence of intra rupture also increased. I don't know what is the experience of other people. Perhaps because you become more and more confident on how to deal with an intra rupture, and you also develop strategies on how to tackle it in case it happens. And many times I would call it, if I maybe apologize to call so, I would call it as an elective intra rupture. So sometimes, when you do the clip arrangements, there will be a rupture, and but you take that little bit of risk while you're putting the clip. So in terms of your question, what is my feeling in terms of intraop rupture? Now, the selection of aneurysms is very important. So if you select the right kind of aneurysm and you have a rupture, you will be able to also handle the rupture very well, whatever the approach is, whether it's a T-renal or a orbital approach.
I think.
May I?
Yes, sir.
Quite frankly, I don't see the advantages of this approach. I have very large experience in neurosurgery and I've done more than 6,000 cases. So I never measured the opening. I'm doing a small one since 80s, lateral supraorbital approach, but I don't see any pride in doing some small approach because the approach opening in the cranium must be good for your skills, for your experience, for the lesion, for the light and instruments, and this is always you have to tailor the approach. And one more thing, I'm coming from originally from Finland, where the people don't have eyebrows. They don't have eyebrows. They don't accept this incision. I have asked it, I have tried it, but especially females don't accept this incision because it is immediately in front of other people's eyes. So I don't see, I can do through 3-4 centimeters opening, but I'm not fighting to make a very small opening because you have to tailor according to the lesion, and I don't think it is appropriate to do in large or difficult aneurysms that kind of small approach. For me, 4 centimeters is okay, but it is not small. This is, for my experience, it's large opening. So this is what I want to say. So maybe it is the geographical situation that my patients didn't accept this incision, and also according to that I was not doing. But I see also that you did also only in 15% of your cases. So what are the other cases you didn't select this approach?
So your point is very well taken, Professor Harsanami. So, an advantage is most of the Indians have very bushy and black eyebrows. And surprisingly, they like this approach. But again, I would like to emphasize that the opening is not small in this approach. The reason is that we do a small fronto-orbital craniotomy, and we also drill the inner table of the skull. And once we do that, the kind of opening we get is almost like a T-renal-like situation. And for instance, when I started doing Professor Perniski's approach, I always felt that there was a limitation of the bone on one side. And that's the reason I didn't like it very much. But once I started making a small fronto-orbital flap with the drilling of the inner table, the opening was quite significant, whereas the results were also quite satisfactory in terms of cosmetic outcome. Plus, in terms of surgical strategy, I found that this approach provides the closest possible distance to the target point. It's just 2 or 3 centimeters away from the site of the opening. And again, the point is also well taken that this approach constitutes only 15% of my cases. So like I've told you in my presentation, I prefer to select those cases where it's preferably an unruptured aneurysm or small to moderate size aneurysms. And these are the type of cases where it should be done initially. But as the confidence grows, you could also go in for more complex aneurysms. So that kind of complex aneurysms which I showed are more like an exceptions. But I showed it just to show that there is a feeling of comfort even while you're handling with complex aneurysms, provided you have enough experience to tackle it. So answering your questions short, it's not a small approach. It's almost as big as T-renal approach. And yes, you're right. In Finland, definitely I've seen people don't have big in fact, many European countries, they don't have thick eyebrows. But in our setup, you can see very nice eyebrows what Dr. Paritosh has. So under those circumstances, obviously, we found it optimal in certain indications.
Thank you, Dr. Sharath. I think we'll move on to the next lecture. If anybody else has questions, they can write to Dr. Sharath and they will answer it. So the next lecture is by Dr. De Oliveira. He is the head of Department of Neurosurgery, a Center of Reference CNS Tumor, AC Camargo Cancer Center in Sao Paulo, Brazil. And he would speak about the very important topic of neurosurgical management of paraclinoid aneurysms. Over to you, Dr. De Oliveira.
Hello, everyone. It's a great pleasure to be with you. Here in São Paulo, Brazil is 3:08 p.m. So I know that most of you is all around the world in different time. I'd like to say how delighted I am to be invited to this meeting. I'd like to say thank you for everyone in the Egyptian society, especially to Dr. Sameh Hassan for this kind of invitation. I'm gonna share my screen with you. Okay, let's see here. I hope you can see my screen. Probably you are seeing a double slide, right?
Yeah, you can play the video. Yeah.
Only one slide. Okay. Okay, are you seeing?
Not yet.
Oh, great. So my topic today is the neurosurgical management of paraclinoid aneurysms, which is an amazing topic. I have no disclosure on this lecture. If you go to the literature, you're gonna find at least 27 different names to define a paraclinoid aneurysm, or names that define any kind of aneurysm arising since the carotid artery leaves the cavernous sinus up to the origin of posterior communicating artery. So in this segment of carotid artery, any kind of aneurysm arising from that, you can call paraclinoid aneurysms. Every time you face the patient with paraclinoid aneurysm, you have to have a neuroradiological assessment, and every single information for the neurosurgical planning is very important. So the angiography can give us information about the intraluminal arterial features, but also the MRI can bring to us the information about the relationship between the aneurysm and the encephalic structures, especially when you have a large and giant aneurysms, when you have some part of this aneurysm thrombosis. So this is very important information to have the MRI, especially in a large and giant aneurysm. Of course, the angio-CT also can give us information regarding the relationship between those large aneurysms with the other vessels, and also the relationship between the skull base anatomy, especially to the bony anatomy, along with the aneurysm in the vessels. When you face a small aneurysm on this paraclinoid region, sometimes we become in doubt if the aneurysm it is inside the cavernous sinus or it is inside the subarachnoid space. So this is a very important question, and unfortunately, there is not a single exam to give us the right answer for that. So this is an interesting paper that bring the optic strut as the landmark when you have an aneurysm under the optic strut. Probably it is inside the cavernous side. When you have aneurysm above it, probably some part of this aneurysm can cause subarachnoid hemorrhage. So this is an important information in the decision-making process.
Excuse me, sir.
Yeah.
Sir, there is a rectangle in the middle of your presentation. Can you please re-share your screen?
Of course.
Thank you.
What's happened? Should I share again?
Yeah, you
Yes,
go back
sir.
on screen sharing. Yeah.
What happened?
You fell off screen sharing.
Okay, so
There was black rectangle in the middle of your screen all the time of presentation.
Okay, should I back to the beginning or should I continue?
As you see, sir.
Should I go to the beginning of the lecture?
Continue, sir. Continue,
Okay.
sir.
You can restart, Mr. Oliveira.
Okay, let me share again.
Now it's okay, sir.
Okay, just a minute. Let me duplicate it. Okay, are you seeing the screen?
Maybe your net is weak a little bit. If it's combined with some other instruments, you can just ask them to close the other instruments. Now it's okay, but the square is in the top.
Okay, are you seeing the screen?
Yes, it's perfect.
Okay, perfect. So also it is important to analyze the cerebral circulation, the flow, so the balloon occlusion test preoperatively, it's a very important information to know if you can occlude or not occlude the carotid artery. If you cannot occlude, you have to go to the surgery prepared to make a bypass. So it's a very important information in the preoperative time. And also in the preoperative time, you have to have the neuro-ophthalmologic assessment because these aneurysms, they're a very close relationship with the anterior optic pathway. So to have a neuro-ophthalmologic assessment in the preoperative time, it's a mandatory step. After that, when you decide to treat these aneurysms with surgery, it's important to know some very basic principles. There are a lot of classification systems for that. I like to use a very simple one, that is those aneurysms arising in the superior aspect of the artery, in the closer relation with the ophthalmic artery, and also those ones with a backward projection. Also, we have
I'm sorry. I'm sorry. I got to get that mute. I'm sorry. Okay.
Okay. So there are some aneurysms arising from the middle wall of the carotid artery. For those in the hypophyseal segment of carotid artery, and also those arising inside the cave. I'm going to talk about that in the future. So for those aneurysms in the upward projecting, we're gonna use a direct or curved clips. This is a very basics, but for those projecting downwards, I have to have some fenestrated clips. So it's a very simple classification. Another basic step is to know the anatomy, especially the bony anatomy in the skull base and the anterior clinoid process, points of attachment in the sphenoid wing and the optic struct in the optic canal. So are the three points where the anterior clinoid process is attached. So when you have to remove it, it's important to drill those bones in order to remove it. When we remove the anterior clinoid process, we expose this small segment of carotid artery, which is the clinoid segment, and you can see here the ring, the distal ring, the origin of ophthalmic artery, the optic nerve, the carotid artery, the cavernous sinus anatomy. So this is very important anatomy. And the only way to understand this anatomy is going to the lab and practicing to open the specimens, cavernous sinus, so to understanding this anatomy is the only way to give a confidence to operate those kinds of aneurysms. So going to the microsurgical principles, we have some very important steps: the positioning, the Sylvian fissure opening, the anterior clinoid process, and the clipping. Clipping is not single to put a clipping and leave the surgery. Clipping is a process. We're going to talk about that. So about the position, when you have a paraclinic aneurysm, it's not necessary to extend the head. You have to put the head, especially in my practice, we put the head parallel to the floor, because if you extend the head, you're gonna put the skull base far away from you. So I like to put in this position. Another basic principle, which is to have a proximal control. And for paraclinic aneurysm, the proximal control is in the neck. So for me, in my practice, we start the surgery in the neck. So we start to dissect the carotid artery in the neck, and then you go to the craniotomy. Remember that we have connections between external carotid artery with internal carotid artery. So if you have to control some intraoperative bleeding, I like to put a clip on the common carotid artery, because if you occlude only the internal carotid artery, you can have some flow coming from the external carotid artery through the ophthalmic artery. So if I need some proximal control, I like to put a clip on the common carotid artery. Choosing the best craniotomy approach for paraclinic aneurysm, I believe that the Iono approach is enough for 99% of the case. I like to do the regular craniotomy. I couldn't agree more with Professor Juha Hernesniemi comments about small craniotomies. So I like to perform regular or large craniotomies. Of course, when you have a large and giant aneurysm, some exceptional case, we can perform an optozygomatic approach, which give us some different angles of approach. So sometimes I like to use that. I'm going to share with you some case that illustrates the way we deal with those kinds of aneurysms. This is a female, 16 years old, presenting with bilateral paraclinic aneurysms with left visual depth. So you see here the campimetry preoperatively. In the MRI, you see this left large upward projecting aneurysm right here, and you can see another one, the right side, When you see the angiography also is consistent with a large paraclinoid aneurysm in the left side projecting upward, and in the right side you have another one projecting downward. So because the patient had a visual depth on the left side, we decided to go firstly to the left side. I hope you can see the video. Are you seeing the video?
Yes, we're seeing it a little slow. It's okay now.
Okay, so you can see here the carotid artery, the aneurysm, the optic nerve, the origin of ophthalmic artery right here. I'm putting a pilot clip just to have the control of the situation. Of course, I'm seeing here the residual aneurysm right here in the up part of the carotid artery. You see that this aneurysm is causing some kind of mass effect of the optic nerve. You see the area where the optic nerve was compressed. So just cutting the arachnoid, we can separate the aneurysm from the optic nerve. I'm going to put additional parallel clip. I can see here also the pituitary stalk right here, but I can see also a residual aneurysm right here. And then puncturing, aspirating, suction the aneurysm, you gain space. So I'm using now a fenestrated clip in order to occlude that residual aneurysm in the inferior part of carotid artery, keeping the previous two clips inside the fenestration. Coagulation of the aneurysm sac, it's useful in some situations. You can see right here residual aneurysm, and also we coagulate a little bit more the aneurysm wall in order to reduce those aneurysms, residual. And then we put additional clip in order to achieve a complete occlusion. The clip was not in a good position. I'm gonna reposition it, and now yes, to get there still a small piece right here, and we put another additional clip in order to occlude completely. I hope the video is running well. And this is the post-operative angiography. This is another mandatory step for me, is to perform a post-operative angiography in order to have a comparison between pre and post-operative, to make sure that there is no residual aneurysm, and also to have a preservation of carotid artery and ophthalmic artery and in every single artery involved in the aneurysm complex. So some months later, we went to the right side. Look at that. It's a completely different, the same patient, but it's a completely different situation. Aneurysm projecting downward. I don't have I cannot see the whole aneurysm complex. We thought to remove the clinoid process, to open the cavernous sinus, to open the dural, distal dural ring. I like to clean the clinoid. This is the third nerve right here, free edge of tentorius. This is the anterior clinoid process. I like to clean up every single piece of the dura over the clinoid, because it makes my drilling process easier. This is the origin of ophthalmic artery. So I start to drill the bone. You can have some kind of bleeding from the bone. If the bleeding is from the bone, you can stop easily using bone wax. And when the bleeding is from the cavernous sinus, you have to use some kind of fibrin glue. So you can see here, now that we drill the points where the clinoid process was attached, we can detach the clinoid from the dura. Be careful because mostly of the clinoids are very thin point like this one. You can perforate the carotid artery with this point. And then we start to cut the distal dura ring. Is the only way to detach this ring is cutting. We cannot dissect it. So sometimes we still have a very small piece of bone, which is the optic strut right here. So it's important to remove it in order to have access to the middle wall of carotid artery. This is the lateral wall of sphenoid sinus. And here is the origin of ophthalmic artery. Now I'm still cutting the distal dura ring in the middle wall of carotid. Look at how easy it is to mobilize the carotid artery as soon as you have the whole circumferential ring cutted. Now you can have proximal control right here in the clinoid segment. You can mobilize the carotid artery. You have the whole control over the ophthalmic artery. And now I'm doing a trapping in order to start my clipping process. You can see here the origin of anterior choroidal artery and the posterior communicating artery. Because it was a large neck aneurysm, I had to put another clip. I'm using a Doppler to analyze the flow in the posterior communicating artery right here, and now in the anterior choroidal artery. So, and this is M1 and A1. So I'm checking the flow in all vessels involved in the aneurysm complex, checking if the whole aneurysm neck is included by the clip, and now to aspiration of the aneurysm in order to alleviate the mass effect of this. And look at how the pituitary stalk also was compressed by this aneurysm. So this, when you have aneurysm with mass effect, we have to achieve complete occlusion, but also to achieve the mass effect relief. Again, postoperative angiograph showing a complete occlusion and preservation of all arteries, including in the ophthalmic artery. In this case, because we could relieve the mass effect very early, the patient could achieve a good recovery of the visual deficit, but timing, it's a very important factor on this recovery. We have published about that with aneurysm present with mass effect with some points of the anterior optic pathways. In this paper, we observed that the visual deficit is related to not one single aspect like direct compression, like we have seen this example right here. Look at how ischemic was the optic nerve here. But also we can have some kind of pulsation over the optic nerve, as we see on this example right here. And you see in some situations like that where the optic nerve is entrapped into the optic canal. So in these situations like that, we have to open the optic canal in order to relieve the mass effect. And also when we have some calcification and thrombus inside the aneurysm, you have to open the aneurysm to remove it in order to achieve the best clip applying on this case, because sometimes the clip cannot put in a good position because of the calcification or even some sclerotic thrombus on the wall of the aneurysm. So The pathophysiology of visual depth is a multifactorial, it's not single factor relation. So we have to identify every single different aspect of this pathophysiology and to choose the best technique to relieve all of those. When you go to the literature and see this kind of aneurysm treated by endovascular techniques, we're gonna see that the rate of complete occlusion, it's low, around 80%, but can be very, very low, around 21%, with high rates of recurrence, 53%, retreatment, 70%, and up to 40% of complications. And it's easy to imagine that it occurs because when you put coils inside the aneurysm sac, you can enlarge the degree of distension up to 34% when compared to origin of the size of the aneurysm. So it's an easy way to explain why those patients have some visual loss after coiling. There are a lot of publication about that. You can have also compression of coil mass of the optic nerve, but the pathophysiology is not only compression. You can have some kind of inflammatory mechanism around the aneurysm sac, as you can see in this publication, in another publication talking about that, especially when you use bioactive coils. So be careful when you recommend coiling for those aneurysms with mass effect, because you have, in some situations like this one, to go after coiling to a surgery in order to decompress the mass effect. Talking a little bit about those aneurysms arising from the middle wall of the carotid artery. This is an example of that. You see a multiple aneurysm, MCA, anterior choroidal artery right here, a superior lateral wall of the carotid artery, and also this aneurysm arising from the inferior wall of the carotid artery. So this is the MCA. So it's a very important step is to widening open of sylvian fissure. This is a natural way, the natural corridor to have access to the vessel. So this is the MCA. So here you can see the anterior choroidal artery arising from very close to the origin of the aneurysm right here. So I have to put a clip in an oblique position in order to preserve the origin of the anterior choroidal artery right here. This is a posterior communicating here. So the ICG confirmed the preservation of the anterior choroidal artery. This is the superior lateral. So I'm not seeing the aneurysm in the medial wall, and the carotid artery, it's attached by the distal dural ring. So the only way to expose this aneurysm is again opening the cavernous sinus. I'm removing the dura of the anterior clinoid process, the drilling of the bone, and then removing the clinoid, exposing the clinoid segment of carotid artery, start to cut the distal dural ring, and after that you can stop the bleeding with fibrin glue, and now you have some visual part of this aneurysm. In this situation, I didn't have a fenestrated 90 degrees clip, so I decided to to apply the multiple clips fenestrating tendon in order to achieve a complete occlusion. I can see the residual aneurysm right here, and then I put additional clip. So now I can see the whole aneurysm sac, including in the clip, and then a new ICG injection confirm complete occlusion, and then preservation of the all vessels. And this is a post-operative angio-CT. When you have an angiography showing aneurysm projecting downward in an oblique project, not a parallel like the previous one, but in the oblique project, we have to think that this aneurysm can be inside a cave. This was described by Professor Kobayashi in 1989 when he described the cave and some aneurysms arising inside this cave, which is a recess in the medial wall of the carotid artery. This is Professor Kobayashi. It was in the Istanbul in the old Congress. I have the great pleasure to be with him. This is the cave. Okay, this is a small recess in the medial wall of the carotid artery. In this original description, Professor Kobayashi showed us that the cave can be small, like this one. The cave can be a little bit larger, like this one, but in 30% of the cases, there is no cave. So in this situation, all aneurysms arising from this medial wall should be classified as a hypophysio and not a cave. This is a nice illustration from BNI group showing what is the cave, and because of this recess, we can have a small aneurysms in this cave. We can have a large aneurysm, but we have also a transitional aneurysm. Some aneurysms arising inside the cavernous sinus, and part of the aneurysm going into the subarachnoid space. This is a very interesting example, and we have to be careful in this kind of aneurysm, because sometimes we consider that aneurysm is completely inside of cavernous sinus, but this aneurysm can cause subarachnoid hemorrhage in the patient. This is an example of this, one of illustrative case of carotid cave. It's the same technique. We have to start with proximal control, the position parallel to the floor, proximal control in the neck. We have control of the carotid artery. Again, look at, you can see the carotid, the origin of ophthalmic right here, the optic nerve. You have the anterior clinoid process right here, left side. We start opening the falciform ligament, but you cannot see nothing. The only way to clip this kind of aneurysm is to open all this bone. You have to remove the bone in order to have exposition and space to put a clip. So again, we go directly to the attachments of clinoid process. Try to remove the clinoid as a single piece. Sometimes we decide to drill everything, but mostly of the time we try to remove as a single piece. Like you see right here, when you remove the clinoid, you have exposition of the clinoid segment. Look at, there is some bleeding coming from the cavernous sinus right here. So Professor Hess's name has published along with Professor Ali Christ about that. It's a very elegant way to stop the bleeding. So after you remove all the bone, you have the exposure of the clinoid segment, we have the carotid artery distal to the aneurysm, we have the origin of ophthalmic artery, and you can see the aneurysm inside that small cave. Remember that there is a bony, the cave has a bony edge in the whole cave, so it's not easy to put a clip, even when you have the whole exposition like this. So in this case, I've tried a lot of times to put a clip, a fenestrated clip right here, but because we have a bony edge in the cave, I couldn't put it. So I decided to put two fenestrated clips in tandem with the tips of the clips inside the cave, and then the residual aneurysm was occluded using a curved clip, as you can see here. The ICG, it's a beautiful device, a beautiful tool to give us the certainty that you have a flow after clipping. So as you can see here, we put two clips fenestrated. The tip of the clips is inside the cave, and the residual aneurysm right here was occluded using a curved clip, preserving the carotid artery and also preserving the ophthalmic artery. So now you can understand better the clip position. So the cave is a cavity which was right here. So because they have a bony edge, sometimes it's very tough to try to put a fenestrated clip in a right position in order to achieve a complete occlusion. So sometimes we have bilateral aneurysms, like in this case, you can see here right MCA and a small aneurysm arising from the infundibular posterior communicating artery right here. In the contralateral, in the left side, we have aneurysm in the paraclinoid region. This is the ophthalmic artery in the medial wall. When you have a small aneurysm like this, here is the right side. The small aneurysm was clipped. Now you can see here, right optic nerve, left optic nerve. And for a small aneurysm like this, we can have some space to have a proximal control here, and you also can try to put a clip here. So you see that the space is very, very narrow, but it's possible to put a clip and achieve a complete occlusion. In exceptional cases like this, now you can see the position of the clip here. So for some very specific cases, the contralateral approach for paraclinoid aneurysm is feasible. Of course, this segment of carotid arteries has been used for the endovascular treatment using a flow diverter. You have to keep in mind that using flow diverter, as you can see in this publication, can change the flow in the ophthalmic artery in at least 32% of the cases. This is a very interesting paper published. It's a randomized care trial and registry about flow diverter. And remember that flow diverter is mostly indicated for unruptured aneurysms. So when you see the results with these devices, you can see the 10% rate of death in this paper with 48% of complications, and the rate of total occlusion reached only 58%. So based on these numbers, I have to say that this is not a good indication. It cannot be the first option for aneurysms in this segment. And also in this paper, some patients have to be crossed over for surgery in order to relieve the mass effect caused by the by the aneurysm along with the endovascular treatment. Also, there are two meta-analyses about these flow diverters, and you see the total occlusion reaching 76% in both of ones, with morbidity among from 5 to 10% morbidity, and mortality around 4%. Again, when you analyze that tool that you use for unruptured aneurysm, and then you have a rate of mortality around 4%, we have to think about that because it's not a good result. And also 76% of total occlusion, it's a low rate, especially when we compare with those series where the microsurgical followed by a postoperative angiography showed to us that the worst result was 81% in 1963. Because we've considered the modern and more recent results, we can achieve more than 90%, or in some series, very close to 100% total occlusion. And so we have to compare that because the microsurgical technique is still providing a better result regarding total occlusion, and I have no doubt about that. So in conclusion, when we face a patient with a paraclinoid aneurysm, we have to achieve a very good assessment with images. Those aneurysms have a very close relation with anterior optic pathway, so a neuro-ophthalmological assessment is very important. We have to remember that the pathophysiology is multifactorial. We have at least 4 different mechanisms to that, so we have to recognize which mechanism the patients have in order to relieve this mass effect. And based on that, the microsurgical management should be considered first, and also we have to have the knowledge about the microsurgical anatomy. We have to improve our microsurgical techniques, where we have to decompress the cranial nerve as soon as possible, and we strongly recommend some kind of intraoperative blood evaluation, ICG, microdoppler, any kind of intraoperative blood evaluation. And endovascular management should be recommended for some alternative in selected cases, because this technique has some lower rates of complete occlusion, high rates of recanalization. It is not recommended for large and giant aneurysm, and in our practice, it's a contraindication for patients with visual deficit, which makes the microsurgical management as the first choice in the treatment of paraclinoid aneurysms. I'd like to invite everyone next week to be with us in this webinar with Professor Juha Hasniemi and also Professor Bin Shu. It's going to be in Brazil, September 9th, 8 p.m., but in China, it's going to be September 10th, 7 a.m. So most of you and every one of you are most welcome to be with us on this webinar. This is a Santa Casa de São Paulo, and you are most welcome to visit us anytime. And this is a C. Camargo also. You are welcome to come by with us. Thank you very much for your attention.
Thank you, Dr. D. Oliveira, for this fantastic lecture. It was great, and especially seeing the results of flow diverters and endovascular methods and your results. It's fairly clear that surgery has a very, very big role to play. We will take some questions. Professor Chaudhary asks whether you open cavernous sinus to make the surgery easier. Is that one of your strategies to do that?
Oop, he may not have heard that question.
Okay. Yeah, yeah. Whether do you open the cavernous sinus often to make the surgery easier, or is that not required? Dr. Oliveira, can you hear me?
Yeah.
Yeah.
Yeah. Okay. No. As you could see, in my first illustrative case, I've shown a large aneurysm, the bilateral large aneurysm. In the left side, I open the dura. I see if I need to open the cavernous sinus or not. In that case, it was a good example in which I didn't have to open that. I could put a clip aneurysm. I could see the neck of the aneurysm, the whole neck. And in that case, it was not need to put it. So the only way to know if you need to remove the clinoid to open the cavernous sinus is to open the dura, to see the aneurysm, to see the relationship between the aneurysm and the bone structures, the relationship between the aneurysm and the optic nerve, and then you decide if you need. And also, you can tailor how much you need to open the cavernous sinus, the bone removal, and also the ring cut. So it's not necessary for every single case.
Yeah. I would ask a question. Which of the cases would you prefer to have a flow diverter placement for the aneurysms as against microsurgical removal? And the second question is, which of the cases you would do prepare for a bypass for these patients?
Yeah. In my practice, the flow diverter is the first choice when you have an aneurysm completely inside the cavernous sinus. When you have an aneurysm that cannot offer any risk of subarachnoid hemorrhage. If the aneurysm can cause some kind of subarachnoid hemorrhage, I have to consider that microsurgical clipping is the best choice for a total occlusion of the aneurysm. So I have to try it as a first option. So the only situation that I consider endovascular treatment as the first option is when you have the aneurysm completely inside of the cavernous sinus, and if this aneurysm is causing any kind of symptoms, because if the aneurysm is asymptomatic, I do not recommend any kind of treatment. Okay. Of course, we have some patients that have other clinical conditions that cannot be a good option for surgery. Patients with cardiac and cardiac problems that contraindicate a surgery like that. So on this situation, the endovascular procedure is also can be a first choice. So I do a preoperative angiography for every single case. And when I have a paraclinoid aneurysm, I ask for balloon test occlusion for every single case. When you have this information, you have a condition to decide if you have to be prepared for a bypass or not. And I always try to occlude the aneurysm using a clip reconstruction. If it is not possible, I have to change my strategy in the surgery for a bypass. That's the way we consider during the surgery.
Yeah. Somebody asks, how many hours each week do you think a resident should practice in microsurgical lab to learn to operate these kind of aneurysms?
How many what?
How many hours each week?
You mean in time? How many years?
Yeah, in time. Yes, yes.
Okay. I don't know. I don't know how to answer this question. Because I think you have to go every time you can, every time it's possible, because to to train the microsurgical technique, to understanding the anatomy is completely different when you are reading a book, when you are seeing somebody else in the operating room, and then when you are personally doing the dissection. It's three different situations. In every situation you learn, but the only way to have confidence to open the cavernous sinus is to do by yourself, first in the lab. So I cannot measure in how many years or how many times you have to go and open specimens and then go to the surgery. I have to say that you have to practice how much you can. And then when you have confidence, when you have sure that you understanding the anatomy, because the first thing in the cavernous side is to understanding the anatomy. Because when now I have to say that my first cases in the Paraclinoid, I didn't understand the anatomy the way I understand right now. So you have to practice as much as you can in the lab.
Thank you.
My teacher in anatomy in 1960s in Zurich, Professor Chayan Thunduri, he was shouting in the lecture, medical study is a lifelong study and anatomy even more. So this is a good sentence, and I think we have to learn all the time. And I never had a good possibility to practice in cadaver laboratory because of cultural and other reasons, but I learned to do. I liked Dr. Oliveira's lecture very much, and it was sound and good surgery. And what I want to say there, I'm using as proximal control, I'm using the intracavernous carotid artery. So I put the clip after clinoidectomy there, and then this is a good place to put the temporary clip because seldom has atherosclerosis, which is very common in China. So it is terrible atherosclerosis here. So this is very good place. For some reasons, it is not attacked by the atherosclerosis, this part of carotid artery. So it is good place to put temporary clip. So this is my way, but otherwise I totally agree what Dr. Jan Oliveira said. So it was nicely, thank you.
Thank you, Professor Ernest Niemi. Coming from you makes me very honored. And as I said, I start the surgery in the neck, but as soon as you open the cavernous sinus, you have the clinoid segment of carotid artery and also part of the cavernous sinus carotid. So you have a space to put a temporary clip. So you don't need any longer the neck for proximal control. So it's, but it's still, I'm still doing the neck proximal control.
So just to continue, so I tried to have balloon control, but I had 3 dissections in internal carotid artery with balloon. So I stopped that. So this was my bad experience. So I didn't like, so it is better to have direct surgery with whatever you put on around the carotid artery or then intracavernous carotid artery. It was very sad to find out that there was no blood coming from carotid artery when you opened the aneurysm.
Right.
And the patient poor outcome.
Right. Thank you very much. I would hand it over to Dr. Sameh. Yeah.
Nice presentation, John, as usual. How are you?
Great, Amir. It's very nice to see you.
And I just also wanted to, well, congratulations for your talk, as usual, and just comment to what Professor Ernest Niemi just mentioned. I think the last time I opened the neck for paraclinoid aneurysm was about 3-4 years ago, and we routinely now use balloon for this aneurysm. And I understand, I agree that there is a risk for dissection, there is a risk of heparinization, but maybe we have been lucky. We do this in the hybrid suite, so maybe the quality of visualization of the endovascular manipulation is better. But once the balloon is there, then when we inflate the balloon, there is no control. It's just by the measurement of the amount of cc of fluid that we need. We can also do suction decompression. And I can tell you over the past 4 years, we never had any hemorrhagic or stroke complication. One patient had woke up with a hemiparesis while intraop angiography was good, and we got an MRI. There was no stroke, but the patient has hemiparesis and improved. So I guess that was probably related to something that we did not found. But in our experience, using balloon has been safe, and specifically if you do this surgery for younger patients who they do not want to avoid an incision in the neck, I think that's definitely an alternative. But I appreciate Professor Hernestimi's comment. That's a risk, so it depends on institutional also experience with that.
I have used that a couple of times. I think I have to say that it's very useful for suction decompression, and also you can perform intraoperative angiography, which is very, very nice to have control, because ICG has some limitations on this region because of the bone. Yeah.
It miss the degree of narrowing of carotid if you don't do intraop angiography.
Yeah.
You think it's good, and then you have a post-op angio shows 70% stenosis. So I think this specifically large aneurysm in 2020, if we do operate on them instead of endovascular treatment, you need to get the best result. If you don't get the best result with this aneurysm, endovascular is they're gonna kill you. They're gonna say, well, we can do much better with the flow diverter, stuff like that, remodel the lumen. And in order for us to be competitive and show that the surgical results are good, we absolutely need to have the best confirmation. And as you said, the best way is intraoperative angiogram.
I think that you have to change the position. You have to kill the endovascular, because they have a very, very bad results when compared with you. So when you have some kind of bad result for a single case, they come to you and try to kill you. But they have results every single day that we could kill them. So
that's right. But
we have to change the position.
You know that the trend is toward endovascular. So it's a treatment that is perceived less invasive. And you and I and all the experienced people in the panel, they know that if you dig into the data, even in our own institution, we might have a mortality from endovascular treatment of ophthalmic aneurysm, but we never ever had a mortality from treatment of surgical treatment of ophthalmic aneurysm, period. Never a serious complication, never. My rate of stroke or mortality is close to zero, but it's an invasive treatment, so that's the problem.
Both are invasive. The results tell us which is invasive or not.
I understand. This is I 100% agree with that, but you know what I'm talking about. This is the trend going toward endovascular. A lot of psychological and financial investment.
Of course.
And the result, the remodeling, when it works, we have to agree, the remodeling of the carotid artery with a pipeline device or any flow diverter, when it works, is beautiful. But it's not 100%.
Yeah.
If it's 95 to 100%, then yes, but we are not there yet.
Yeah.
Anyhow, thank you very much for your talk. And
thank you for your comments. Thank you very much.
Okay, thank you all. Okay, thank you. We now open a discussion for the panelists to be again discussion about all four talks and lectures. Please, the panelists, unmute yourself and ask your question directly. Thank you. Okay, I will share my screen now to Professor Luton to answer questions from his lecture. Okay, sir, are you here? Professor Lawton.
Yes. Can you hear me?
Yes. Yes, sir.
So
now questions are
so
shared.
do you want me just to answer these?
As you see, sir.
Yeah, okay. Well, so the first question is, how often do I use neuronavigation to reach my target? And the answer is that all the time. I use navigation 100% of the time because I think you really need to have some sort of an imaging guidance system that takes you to your target. Now, that said, I think it's very important, and I hope this came off in my speech, was that you need to rely on the anatomy because navigation fails, navigation sometimes glitches, there can be inaccuracies, so it's important to also correlate your target with surgical anatomy. So the answer is use navigation, but also train yourself to use anatomy as your own pure navigation. Now, the next question I see here is, thank you very much for the lecture. How long does the patient stay on the ventilator? In our experience, the duration is much long. Thanks. We try and extubate our patients immediately. We generally don't have any trouble doing that. If there's some concern about respiratory drive, and typically that comes with surgery in the medulla, then there may be some slowness to extubate, but there may also be some patients that are left on the ventilator if the case finishes very late in the evening. But by and large, the vast majority are extubated immediately.
Thank you, dear Professor, for honor today. Is there any comments from you or any questions to any lecturers? Professor Norton, are you here, sir?
Yes.
Is there any comments or add-on for your lecture?
Oh, you mean additional comments from me?
Yes, sir, if you want.
Oh. No, I don't have anything additionally to say. I'm happy to take questions if there are questions.
Okay, sir, I think this is end. And thank you for honor today. Thank you, sir.
Thank you.
At the end of session, I'd like to thank our dear professors, speakers and moderators, Professor Yuha, Professor Lawton, Professor Boyle, Professor Dahdashti, Professor Chandra, Professor De Oliveira, Professor Manas, and Professor Dandy. I'd like also to thank organizers, Professor Boba, Dr. Bizwas, Dr. Joanna, Dr. Helmi, Dr. Abiram, and Dr. Jupiter. I'd like to remind you all that our session will start tomorrow, half an hour before time we started today. And I'd like also to invite you all to our endoscopic spine congress that will be at 19 and 20 September 2020, and we will send link of this Congress on all our 33 groups. Thank you. Now, if any moderator or speaker want to say something, floor is him. Thank you.
Okay, Sam, thanks for putting all this together. This was quite a lot of work. You did a great job, and we'll see you all tomorrow. Thank you.
Thank you.
Thank you.
Good night.
Thank you.
Thanks.
Thank you
Good
very
night.
much.
Thank you. Thanks. Good night.
Thank you.
Thank you.
Okay.
Okay, thank you all, and we meet you half an hour before this time tomorrow. Thank you all. Thank you, dear Prof.